Then treatment. Okay, everybody, we are live with tonight's class. It's not pelvic pain, it's lateral thigh and hip pain. Broadcast 22. This is part 22 of the Bodyworkers Mastercourse here at Water Tower in Chicago. And we are looking at protocol 21 today. So when you go online to go to your browser and you type in our website for myofascial.com, boom, it takes you to our website. You can click on anything that says Bodyworkers Mastercourse. Ta-da! And down here you find the free downloads. So here's the master chart that tells you every part of the body, the pain key numbers, and which muscles cause what. So here we're going to be looking at pain key number 21. And if you just shoot on over to 21, you see 21, lateral thigh and hip pain. And there the muscles are listed in ranking from the most likely to the least likely to cause pain in that region. So tonight our first muscle will be the gluteus minimus. After that it says L4 to S1. You guys know what that means? That means those are the nerve roots. But wait, we don't treat nerves, do we? Well, we don't treat nerves, but we treat muscles along the spinal column that affect how much space there is for nerves to travel through the vertebral canals. Also, we treat muscles that send information into the dorsal horn of the spinal column and affect nerves that go all the way up and down the spinal cord. So yes, we do indirectly treat nerves. So gluteus minimus, L4S1, that's where you do your skin rolling to check for hypertonicity, supersensitive spinal segments that might need treatment, and then you would treat the rotatories and the multifidi in that region if you found some there. Then these little numbers right here, 45 and 51, those refer to our range of motion charts. So then we go over here to 45 and 51. There's 45. This says that the external rotators test. That's how you would check for the gluteus. And 51. This is a wonderful test. Can you sit with one leg over the other, not having any space in between the two thighs, between the hamstring on one side and the knee on the other? You can see how the gentleman there is failing that test. We had a better name for it, or knee crossover test. Yeah, there is knee crossing test. Okay, so those are the two tests that you would do if you were checking the most likely muscle to cause pain in that area. Again, the gluteus minimus. All right. Of course, you have to know where the muscle is in order to palpate it, and you have to know where the referred pain pattern is. So gluteus minimus, we go to our referred pain pattern charts, or I am a techie, as someone just accused me rightly, and I just go right over here and why don't you just type it in? Glute minimus referred pain. Pow! And there comes some images. Anything you could want, there it is. Okay? Or you could look at your handy charts, referred pain for the glute minimus. There we have it. For the ones in the front, it gives pain running all the way down the lateral side of the leg. What's today's course? Lateral thigh pain. So there you have it. Plus the circular spot right over the glutes. Or if they're more medial, then the trigger points will cause this, which is pseudosciatica. It mimics sciatic pain, and a lot of people complaining of this kind of sciatic pain pattern actually have trigger points to gluteus minimus. Take this person, have them sit on a chair, bring one leg over the other, check to see if the hand can pass between the knees, then switch, put the other leg over the other, see if the hand can pass to the knees. If the hand can pass to the knees, they have a tight gluteus minimus. Or you could do the lying on the table and foot rotate in. That tests all the external rotators, including gluteus minimus. Okay, so that's how I use this chart. What if you don't have the range of motion charts? Well, that's no problem. We don't leave anybody in the dark. You can go to our website again, and here we have range of motion testing. Just click on that. It's under the free chart and the free protocols. Here's some free forms like the tracking form. Oh, you love the charts? Thank you. The tracking forms, evaluation forms, all that other stuff is here. Where I had to change access permissions so everyone can get in now to that. Range of motion testing. You could just have this with you. Here is, not only do these have every range of motion test listed by number and how to perform them and the pass and fail indicators, but also areas to mark down the results when you're treating someone or evaluating someone, okay? So you'll have, every time you come to class, it's good to have some of these out. It's good to have one of our symptom sheets, which we do. Let's see. We start off every visit with a symptom sheet like this, where the patient draws pain anywhere that they're experiencing it in the body, and then they rate the severity of the pain underneath. And that is also included. Okay, that's in the, when you go to the website, that's included in this section of patient management eval and tracking forms. That is right here where it says daily soap notes and super bills. Okay, when you open that one, there's your symptom sheet. Beneath that is some ideas of daily notes you could, write on as a therapist. Then a super bill that we use just for samples for you, with indicating some of the diagnoses we frequently treat. Remember, as body workers, we don't treat diagnoses. We don't treat conditions. We treat muscles and fascia, which cause conditions, right? Okay, and diagnoses. But we're careful not to step on the doctor's toes, because they treat, things like 1729.1, and they treat things like 524.6. We don't. We treat muscles and fascia. But here's some diagnoses that all can relate to problems caused by muscles and fascia. Okay? So, but there's some sample things there too. This is especially good if you work in an integrative office with other practitioners like chiropractors or doctors, things like that. But anyway, so that's all there for you. So you're ready to go. You've got your chart. Ta-da! You've got your range of motion tests. And you've got your protocol 21 for today. Let's take a look at that one. Boom, there it is. And then you're all set. And if you've got a buddy to practice with and a few of these self-care tools, you're good to go. Tonight, at the end of class, we have a special treat. Not only is this class a very, very rich class, it has not only just these list of juicy muscles we're going to be treating, no more tiny muscles, behind the skull along the sphenoid bone like the pterygoids or anything. These are big, juicy muscles. You can get your elbows and knees and every kind of body part into these. They're very fun to work on. But all sorts of diagnoses like restlessness, squirming, everything from nerve compression, sciatic problems, femoral cutaneous nerve compression. We've got chondromalacia patella, where they believe the patella is getting soft on the back side. Water under the knee, high riding patella, patella pulled to the left, lots of patella problems. So these muscles cause all kinds of juicy things. And at the very end, I'm going to teach you, for the first time in the Bodyworkers Mastercourse, a little bit of kinesiology for some of these muscles, because we're going to talk about something that's really easy to fix that'll make you a hero almost instantly. You do it anyway, but this is a really cool way to show off. It's called a hip compaction. Basically, all it is treating the origin and insertion of one hip muscle when the ball and socket have compacted together, causing weakness of all the muscles. One will be exceptionally tight, and you treat the origin insertion of that muscle where right at the Golgi tendon organ, where it's causing that muscle to lock down so hard and neurologically inhibit all the others. You treat those two origin insertion points right over the GTOs, and it makes you look like a hero, because that person's hip will suddenly, all these muscles will turn back on and they'll feel a lot stronger. And I'll show you a few muscle tests that'll make you look like a hero. It's a good way to show off and also teach your patients a few things. So I think that being said, we are ready, are we?
Yeah, we're ready.
It's 2 minutes to go. That's it. Good. So get your water, everybody. And in the meantime, Sharon will start welcoming everybody.
Hi, everyone. So today we're doing lateral thigh pain. And lateral thigh pain today. So everything that causes pain in the lateral thigh area. We have a few guests here. They'll be working with us. And why don't you go ahead and stand up? Yeah.
All right.
So
therapist guests.
We have therapist guests. Tell us your name.
Linda.
Linda's here, and tell us your name.
Camille.
Camille. They're both here. They're both therapists. And tell how many years you've been a therapist.
This October will be 35 years.
Yeah, and Camille.
34 professionally, 36 non-professionally.
Wow. I don't know what that means.
Yes, but we don't want to talk about that. Okay, so you were here last week.
Yes.
I'm glad you came back this week. That was good. I'm glad you did that. And so you prefer coming here in person rather than watching on the broadcast, you were saying.
Yeah, I don't have enough data, and I'm a non-techie, so
You're a techie.
She's not a techie.
I learn, by observing and in person.
That's great. So it's good to have you here, and other people could come and be here with us as well.
Yes.
And you have
I've been here at every class.
Yeah, that's
I
right.
missed one, but I've been here since the beginning.
Yeah, definitely.
That's great. Now, last week you had some. We got you some shoe inserts because we noticed you were hyperpronating. And what did you notice this week?
Amazing changes with these ProKinetics.
Yeah.
And I wore them so hard that I wore the P off on the Pro. But what I really appreciated was, Justin, the analogy that you gave about me being like on one blade of an ice skate instead of the tripod.
Right.
And that's how I felt. So the biggest change, I would say, has been my balance.
Wow.
Now I'm walking and I'm not fearful every step that I'm going to trip or I'm going to twist my ankle.
Yes.
And on Saturday, I walked all the way from the Fullerton L to the Mag Mile, making stops in between because I was so zealous. I would have never been. I would have never been able to walk that far. So I was thinking that these would really be great for like seniors or people that have balance problems because my brain is still trying to. My brain is still adjusting when I don't have them, when I'm not wearing them.
It is.
I feel like my brain is still trying to adjust my feet to get used to making contact with the ground. I don't know if it's possible or not.
Yes,
No,
neurologically.
you're absolutely
so
right.
what these are is proprioceptive devices.
Yes.
It's bringing the ground up to your big toe, where your big toe doesn't have to turn, your foot doesn't have to turn, your big toe find the ground. And then that kind of makes you off balance and puts you forward, it causes you to have, and in your case, you were quite uneven.
Yeah.
And then when we put them in, it made her stable, real stable and even.
Yeah, so thank you to Bjorn and Milady.
too.
Yeah, that was good. That's good.
Thank you
that's
to
good.
Bjorn and Milady.
So
who
I want to
run
give
the
thanks to them.
Very
That was
ethical
great.
company.
Sharon, of course.
Thank you.
Yeah, y'all definitely want to talk to Bjorn and Milady. They're beautiful people out in Seattle, and they own mortonsfoot.com and all the ProKinetics and the posture control insoles. And,
Right,
and it's right.
right.
The reason that we only do 30% of the total deficit, the lifts are not the full amount, they're part of the amount, is because we want the brain to get that training. It is a proprioceptive training device. So
That's right.
that's
right.
All right.
So today, look at all the muscles we're going to be
Oh
treating.
yeah, let's look at them.
We have some nice muscles here. So we got the gluteus minimus.
Oh yeah.
So here's the preferred pain for the gluteus minimus coming up here. Let's take a look at this. So maximus and then minimus will be coming up here. Here it is. So let's go ahead and look at the minimus, and here you can see how it causes that pseudo-sciatica, the pain coming down the outside of the leg, also in the back of the leg and the thigh. So that's your gluteus minimus. And the next one we're going to take, and now that gets innervated by L4 to S1. So we want to look at if we have any supersensitive segments there. And this is the most likely one to cause lateral thigh pain. Vastus lateralis, the muscle that's right there, also could cause you to have pain there. And it has an interesting pain pattern of vastus lateralis, and we can take a look at that. because I don't have them noted quickly there, but here you go. So here's our vastus lateralis. It has a very interesting pain where it goes underneath the kneecap right there. So, and it goes up, way up into the hip and causes you, so if you were trying to sleep at night and you laid on these, they would be pretty, because you want to lay on the other side, and then those activate, then you cause you to lay on the other side. So it's also true of many of the muscles, the gluteus medius and the piriformis. If you're going to lay on them, they're going to make you want to go to the other side.
Sharon, is it the case that, I found this in my practice, is it the case that people that have wider hips sometimes have more trouble with this vastus lateralis?
Well, they could, yeah, they often do. You do
It's
see
very,
that.
very common. It's extremely common.
So here is our piriformis, and oh my gosh, it causes so much dysfunction and nerve compression, and presses on all your.
Heck yeah.
So you can have referred pain from the piriformis here, but we can also have numbness and tingling and nerve compression all the way down the whole leg and all the way down to the sole of the foot.
That's right.
So
I think it's 40% of people, the sciatic nerve runs right in through the belly of the muscle. See,
So
sometimes it goes underneath, and 40% of people it pops right through it.
Yeah, so it could really cause compression of your sciatic nerve, and also many of your other nerves and the blood vessels.
And I'll just say one thing: when you're treating the piriformis, always make sure you look at the iliopsoas, which is its opposite antagonist muscle, because problems in the iliopsoas can cause problems in the psoas and the piriformis back here too. So they're a great pair to always pay attention to.
Piriformis is innervated by S1 and 2, and also the obturator and some of the other short rotators are also L5 to S3. So this area we'll be looking at as part of the treatment as well.
Great.
The tensor fasciolata usually causes that pain right into your greater trochanter, and so that's an important one. Oh, I could find it quick. Well, I'm not very good at finding these quick.
No, you're doing just fine. And maybe that one I'm thinking of with the wide hips, actually. Maybe that more.
Here's our gluteus maximus trigger points here, and you can see that you're on them because they're more superficial, and they tend to cause it right along the sacrum and into the ischial tuberosity, and a little bit over here towards the greater trochanter as well, and it gives you pretty good tail pain. So that's that's our gluteus maximus. And let's take a look at a few more of our muscles that we're going to be treating today.
Further down. Fasciolata. Here it is.
Oh, here it is. Oh, there it is. Okay, here's our tensor fasciolata. Here's the muscle, but here's its pain pattern right here. So it makes it hurt. It makes you feel like you have greater trochanter bursitis, and it could make you get that diagnosis when you really have a
bursitis. Yes. Yeah. Everybody knows the itis myth, right?
Yeah, itis.
When in doubt, give it an itis.
I just don't know what muscle is causing this problem, is what it means.
So we're going to be treating also the rectus femoris, and it's the least likely to cause pain in the lateral part of the thigh, but you can see that way up here, it causes significant knee pain, and it also helps to fix the kneecap, as well as the vastus lateralis. We already went over that.
Yeah.
So I think we took a look at them all.
Rectus femoris?
We did. Here's rectus femoris right here. Here's our rectus femoris.
Exactly.
And that's this pain pattern right into the kneecap there. But look at this. Most likely trigger point is way up here near the groin. So those are.
And what was the vastus intermedius? Was that this one?
Oh, sorry. That's right. It's right here. So here's the vastus intermedius, and the pain. It causes you to really have your kneecap stay in one position. So that's the vastus intermedius. Let's see if that nice picture. Here it is. That's the intermedius has a trigger point up there.
So if you're rolling the patella around and it's real tight, then that might be a muscle?
It could be, yeah. Well, all of our quads are going to be important.
Yeah.
So the vastus lateralis could be pulling it out to the outside, and sometimes when you have first metatarsal deficits, or you need that lift for the first toe, a lot of times you're compensating by tightening up the muscles like the gluteus minimus, medius, and the vastus lateralis. So here, this could fix all of these can fix the kneecap, and then when you try to bend your knee and kneel, oh, it's so much pain, or go up and down stairs, especially downstairs. It goes, oh, that's really horrible pain. And that's often just these muscles are a little bit tight.
Oh, wait, is that what they call chondromalacia patella?
Well, really it is. It really is. It just means sick patella. Anything wrong with the patella. So anything wrong with the patella could be called chondromalacia patella. So we'll be fixing chondromalacia patella.
Yeah.
And lateral cutaneous femoral nerve compression.
Yeah, like they have this term called cinema sign. If you sit in a movie theater for 2 hours and then you have trouble getting up because your patella hurts, they call that the cinema sign. That's supposed to be.
That's it.
Yeah,
Okay.
yeah.
That's it.
They don't think that's muscular. They think that magically your patella got soft and squishy underneath during the 2 hours you sat and watched the movie. So chondromalacia patella. But
Sick patella.
It's muscles.
So today, this is our protocol that we're going to be using. 21, and this is what you would use to follow how you might treat yourself every day. So here are the muscles that we're going to do self-care on, and here's how to do self-care on those muscles, how to do the self-care, and then stretches that you might incorporate in throughout your day.
Foam rollers are wonderful, guys. They really are wonderful.
Yeah, and you can get them from Amazon.
Yeah, Amazon.
In a day.
Yeah. You can get something in an hour sometimes.
Yeah. So today I was going to start with self-care.
We're mixing it up. We'll start with self-care. Great.
Yeah, so I thought, why don't I have you go ahead and take one of these? Oh, you have, she brought her.
I did my homework here.
She did her homework.
I don't have the pretty colors though.
She printed out hers. Okay, here's yours, and here's for you. So this is our self-care here, and so we're going to go ahead and use our tools and treat ourselves. And sometimes when I do that, then people learn to treat themselves and they don't need any more treatment.
Yeah,
what do you think of that?
I think it's okay. 'Cause they refer more people in anyway. You know.
That's it, isn't it? Yeah. So let's do the most likely muscle. Let's treat the gluteus minimus. Okay.
Gluteus minimus.
The gluteus minimus. So all together we'll work. So now we can do it different ways. One way we can do it is on the floor, and I'll use this ball. And
I'm not good on the floor.
So and other people would like to do it on the wall. So here we can do it, and this is a little harder.
Any softer?
Well, last time.
I'm delicate. Yes. I don't know if this is softer.
Yeah.
I'll do it on the wall.
Yeah, you can do it on the wall. Okay, and that's great. So and then we'll use Stephanie. You could come.
That one's soft.
You could come and work with me on the floor. So let's have you work maybe right here. Okay. On the wall right here.
And I'm just going to watch jealously.
And Stephanie, you could use this one. Okay, so we can. So why don't you go ahead and put your hip on the wall, and I'll show you. So let's take a look at your picture. So the muscle we're going to treat is the gluteus medius, and let's go ahead. Which ball do you have there? The little one there. Okay. So you're going to find your greater trochanter. Turn sideways towards the. Find your greater trochanter. Go just above it. Just above it, and then you're going to press into it. Yeah. So let's see how you're doing. So you find your greater, so go right above it. So find your greater, go right above it.
Right above it.
And that's where your gluteus minimus is.
Everybody show, where's the greater trochanter?
So here's our greater trochanter,
Yep,
right there.
Bony protuberance right there.
The bony part right there.
Right above that is where the gluteus minimus inserts, right?
Yeah, right above, right here. Yeah. So right here, so up there.
There you go.
So this is a really good way to do it is to get down on the floor,
This is tender.
and then you could put your gluteus minimus right on your ball. Now what you want to do is you want to you're micro stretching. So you're getting in before we macro stretch, before we use the muscle. Then we're going to go ahead and micro stretch and get in there and stretch the fibers and push out the painful sensitizing chemicals and allow the blood supply and the nutrients to get into the muscle. So we're looking for a painful spot, and when you find a painful spot, you're going to press on it, because when you found a painful spot, you found the spot that had the painful chemicals in it, and that's the spot you want to squish those chemicals out.
Sharon, is there any rule on what size or hardness of ball to use?
Well, you want it to be, you want to be able to feel it, but you don't want it to be so painful that you can't stand it. You know?
We generally have two size balls of the inflatable kind, of the 5-inch and 7-inch.
Yeah, so here, this is a good size. This is a really good size.
That's a
And this is about
5-inch.
the size of a 16-inch softball. So sometimes if you want to go a little harder, you start to go into a little bit like a softball. But this is a good hardness, you see.
For hip muscles, that's
Yeah.
pretty good.
This is good. Then show us the bigger one.
And the bigger one would be if you're
This
more
is 7.
sensitive.
Yeah.
And
So
that's
you
good for
mhm.
back muscles and
Also,
bigger muscles, yeah.
We can also take some air out and make it softer yet.
Yeah.
So we get right in there, and we'll take a look at our gluteus medius, and go all the way around to the back and look around for painful spots. And when you found a painful spot, that's when you're going to stop and press. So let's go ahead and look at the other side. Did you find any painful spots? She did?
Yeah. We sure did.
So let's look
What
at
does
the
it
other
mean
side.
when it feels like an electrical shock it's shooting?
Okay, so that would mean that that spot would be
Is
causing
irritating
that
nerve?
feeling. So if you had that feeling when you were walking or anything, that would be...
No, I'm just having it with the ball.
Well, I know. I'm just saying. That's what it's saying. It's saying that it could cause that pain. You know, in other words, you're accessing that. It's expressing that if you were to use that muscle, you might have that pain. So we're fixing it. So the ones that you're feeling, that's the ones you're fixing. But you're saying you didn't feel that before. Us adults are filled with muscle dysfunction that we don't fix. And that's why we can't do this, and that's why we can't do that, and that's why we can't do what we used to be able to do. That's why we can't, get up and down off, out of chairs as well, and things like that. So, in other words, if you use that muscle, you might have that pain.
Hey Sharon.
Yeah.
Would you mind if we looked at the range of motion tests as we did the self-care on the muscles too?
Okay, go ahead. Yeah.
Okay,
So one of the tests for that one would be the knee crossing test.
Yeah.
So let's go ahead and let's do the test.
yeah, let's have someone sit.
Go ahead, sit here.
Okay.
We'll do the knee crossing test. So let's see if you can cross your knees. So go ahead and cross. Okay, that's a pass. There's no space right here. Go
That's a
ahead.
very
Let's
nice
try that on the
pass.
other side.
And Stephanie, how painful were your glute minimus trigger points? Not
Okay.
very tender.
So
How about
let's-
some of you had some
One of you
tenderness?
go ahead, go sit down. Let's do the test.
Yeah.
Then we'll do another test.
Yeah.
Sure. Okay. So that's pretty good. She's got about 1 finger space, but very
Yeah, a
good.
little space in between.
Not too bad. And on the other side, so here it's about 2. So on one side it was 1 finger space, and the
You
other
see
side
how
2.
they don't completely.
Yeah.
That's trigger points in gluteus minimus causing that. Isn't that
Yeah,
cool?
and gluteus minimus, medius,
And muse, yeah.
in pure form is,
Yeah. I mean,
yeah,
it-
all of those, yeah.
Yeah.
But especially the one we were just
Check
talking
it
about.
out.
Check you. Okay. So let's go ahead and have you cross your legs. And so here,
Ooh, see.
you having some space. So here,
There
that's
you
2
go.
fingers, difference. Okay, let's try the other side.
It's lucky I'm holding the camera actually for this one.
Okay,
You
here.
see,
Yeah.
you can get lots of
So
space
you
in there.
can, well, that's not lots, but it's
Well, all
some.
right, sorry.
Some space, and so the goal would be to have no space, and put one leg over the other. So keep doing the self-care, so you can do that.
Yeah. Do a little self-care, recheck it.
So
Do a
then
little
you can-
self-care,
yeah,
recheck it.
That's good.
Exactly.
Okay, so another test. Let's do it. Stephanie, could you lay down for us on the ground here? Okay, good. So another test that we could do is turning our legs in. This is the Fieberg's test, so internal rotation. And so we want to see if we can get this to measure maybe from the from where the metatarsal head is to the floor. That's about 3.5 inches.
It should flop to the floor.
Mm-hmm. So here, so let's go. We could do. I got a little measuring tape right here. Okay, so with very little effort, you should be able to get your foot to the floor, and that's 3.5 inches. Okay, so mine is 3.5 inches. We write down on the range of motion test.
So she passed the knee crossover, but
Yes.
failed this one.
Yes.
So maybe it's
So it's also the other deep lateral rotator.
exactly. So maybe
Yeah.
piriformis or something is
Piriformis
more
or the
likely
Camillus
indicated.
or any of the other deep lateral rotators. So okay, so roll to one side.
So then that
Get up,
becomes
yeah.
the goal for the patient. You
Yeah,
say,
yeah,
all
yeah.
right, so
you
good.
guys-
Now we have a way of seeing how successful our treatment is.
Oh, yes.
Let's get your. What if we got that to Sharon would say, what if you got that to rotate 3 more inches?
Yeah.
What if we did that?
might-
Can you
we might-
imagine yourself having less pain if we
We
did
might be
that?
able-
Wow, you sound just like her.
Somebody brought in pictures of me and started putting those captions under the picture.
She's gonna have her own comic strip.
Okay, so now we're going to go right around the greater trochanter. Actually, let's do the sit bone. Let's do the ischial tuberosity. So bend forward and go all the way around your ischial tuberosity, and go on the inside towards your tailbone, and on the outside go
I don't
all
know
the
if we
way
can
around.
reach it with this ball.
Okay, so
You need a little bigger ball?
Yeah.
I got a nice ball for you. So you go ahead, Stephanie, you try it. So go ahead. You're going to go all around the ischial tuberosity. You're going to treat all the deep lateral rotators.
Are we above the ischial tuberosity or beneath it?
Around it. We're going
Okay,
around
around
the
it. We're
whole
going
way.
all
So
around it.
On
Okay.
the inside of it, on the outside, all
Sit
around.
bone. sit bone is right there where your hamstrings insert.
The sit bone. Here's a bigger ball. I got a bigger ball. Okay.
This one is too big.
Okay. Yeah, that's too big.
This
That
one's too big. I need something in between.
Yeah.
Oh, well.
Okay, so here you're looking for taut bands right there, all around the sit bone, all around the sit bone. And this the test for this. Okay, what's the test for the this is the gluteus maximus.
Gluteus maximus. Oh yeah.
So we know
Okay,
this is one of the things we're going to learn. This the gluteus maximus test. So I'm going to do the one on the wall with you, so you can see how to do it next to you. I'll be right next to you guys. Right, I'm going to be right next to you. Okay, stay right here. Don't go anywhere. Okay, so for this, what you do is you put your butt right. You put your tool right on your ischial tuberosity, and then you go around and around and look for painful spots all the way around, and look for them. This gets your gluteus maximus and all the muscles underneath.
It's good for breakdancing too.
Let's do the other side.
Yeah.
So we're going to get all the way, so get really down low and get all the way around your ischial tuberosity.
Oh, I am
Look around
really
for painful
jealous.
spots.
Oh, that looks so good. You know, I have a personal favorite ball. The tiger ball with the rope through it is a bit expensive, but that's a really nice rubber ball I like too.
What are we trying? What test are we trying to pass?
The glute maximus has got to be
the armpit test.
The knee to the armpit test.
All right, let's see who can do that test.
Okay.
Okay.
Maybe toe
let's try.
touch
Let's
too,
try
right?
it on Stephanie. So,
okay.
So we're gonna try it on Stephanie. So we're gonna go knee to the opposite armpit test. Oh my gosh, she's just about passing it. She's way out of the pain zone.
Yeah.
She's in a really good condition, but she still could get a little better. So, and she can feel it. So what if you rolled your whole glute max and see if you couldn't keep getting that further, closer and closer. Go ahead and push towards me. Resist and relax. Oh, it's getting closer. Push towards me. And relax. Oh, it's getting closer. Push towards me. Okay, good. So the way you measure for that is you go from the superior patella to the kneecap. So here, but you're just basically you're trying to get your thigh to lay on your chest.
To the sternum, you mean?
Yes, to the chest, to the sternum. What did I say?
You said superior patella to the kneecap.
Oh, okay. That was good. That was good.
Yeah.
That's 8 inches from the superior patella to the chest.
Which would be a big problem if you had that distance between your patella and the kneecap.
Okay, here.
Ooh,
And so
little
we're
worse on
going
this side.
towards the opposite shoulder, and this is about 7.5 inches.
Okay.
Press towards me and relax. So we're giving you a little bit of resistance. Push. Good. Okay, so your goal is to easily get your knee to lay on your chest. Right, girls?
Right.
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 Okay. That's our goal there.
Okay.
And then we're going to be pain-free. Okay,
Yes.
we're not going to have any trouble with sexual dysfunction or anything. Or pelvic floor or pain anywhere. Okay, so the next thing we're going to treat, we're going to treat the piriformis, okay? So for that, so let's think about where that is. So let me
By
show
the way,
it on
guys, that
somebody.
was 34, right? See? Right there in your chart, 34. And also
So-
35 and
So
36
here's
are
our
also,
piriformis. So
are also from glute
it
max.
attaches here on our bony part, the greater canter. That's coming over here and goes underneath the sacrum, about mid sacrum there.
Yep, it gets
So this
wider
is-
as it goes out. That's why it's called piriformis, because pear-shaped.
It's yes.
Because it's
Yeah.
narrower here,
Mhm.
and then it widens out.
So
as it
for
goes.
that, let's treat our piriformis, and it's nice in some cases to have a little a pointy ball like this, a nice hard ball. So you could come right onto the wall, and you could let's find your greater trochanter, your hip bone, and then you're going to roll from the hip bone to the sacrum, and you're going to look for painful spots between your hip bone and your sacrum. Hip bone and sacrum. I found a little bit of a painful spot.
Oh, I found the very painful spot.
I'd have to press harder for a painful spot. Let's look on the other side. So again, we're going to find our greater trochanter, and we're going to roll our ball all the way here to the mid-sacrum and back again, looking for taut bands and painful spots.
Yep.
So here, we take a look. So let's feel right where the muscle attaches. Let's feel right where it attaches. So we'd like to treat the attachment, We like to treat the center of the muscle,
Yep.
and the neuromuscular junction, and we like to treat the other attachment as close as we can underneath the sacrum. So look for taut bands in there.
Anybody know why? I mean, not only are there trigger points, but there are nerve control centers in the belly of the muscle called spindle cells, and at the edges called Golgi tendon organs. Those control the tone of the muscle. It's good to treat those.
So it's very nice to treat the neuromuscular juncture, because that will help you to get rid of the referred pain.
Yes.
But it's also really important to treat the attachments.
Yes.
Otherwise, the muscle won't be able to contract.
That's right.
Yeah. So okay. So what's the test for this one?
Piriformis has 45, 49, and 50. 45.
So let's go ahead and let's.
I don't think we do that one a lot, do we?
Well,
do we?
We could do that one, but the piriformis would also be, of course, this knee crossing one would be good for that one. Also, this one here, the coffee table one, and also this one here is still good, as well as this one. So those are all pretty good.
Yeah.
Let's check it. So one thing that you want to be able to do is to be able to get your toe in. So how could we do that standing? All of us, let's try standing. So we can test ourselves. Am I able to get my toes all the way in? Can I get my toes in? So that's good. That's a good. Then let's go. Can I get my toes out?
Right.
Can I get my toes in?
Left side having problems.
Can I get my toes out? So then you know you can
Left
feel.
side having big
And
problems.
a good exercise for this after you've been pressing on it would be to go ahead like this and turn it in and turn it out.
Right.
And turn it in and turn it out. And turn it in and turn it out. Now on the other side. Let's turn it in and turn it out. And turn it in and turn it out. And turn it in. And then let's walk around in a circle. So let's all turn to the right. So turn it out.
Range of motion
And turn it
training.
in. Turn it out. So use the right leg. Turn it out. Turn it in. Turn it out. And left leg. Turn it out. Turn it in. Turn it out. Turn it in. Turn it out. Turn it in. Turn it out. Okay. That was good, girls. That was good. That's good.
And you shake it all about.
Okay, shake it off. Good.
Good.
Okay. So that's good. So we're able to treat the piriformis, the gluteus medius, the gluteus maximus. So those were good.
Wow, we nailed a lot of muscles real fast. That's great. Great.
And we tested them, so that was good. Those are a couple good tests for them.
Yep.
Let's take a look at the quadratus lumborum. Okay, so different ways of treating that. So let's have you guys sit over here on the chairs here.
I'll remind everybody of the referred pain for that. You remember the QL is...
So we're going to treat the quadratus lumborum and the vastus lateralis. Okay, and let's have we'll have you sit on the floor. And let's see. I have a little special tool here for. Okay, here we go, right here.
Here it is. Sorry. Put the QL right
Okay, so
here,
here we're
guys.
going to use this tool.
See, it's
this
the
tool.
main lateral
This
bender of the spine,
And
right?
where's your papers?
And there's
Okay,
the referred pain.
Here's yours.
Some lateral thigh
So we're going to
pain.
be treating
Also
the lateral
achiness around
right here.
ridge of the
That's
ilium,
a lot.
crest of the
Vastus
ilium.
lateralis
Plus you can
and
get some
the
achiness up at the attachments in the ribs and at the here too. It's not referred pain, but it's actual pain in the muscles. That's, yeah. Cool. All right, let's look.
Okay, so we have different ways that we're going to be treating, one way would be on the floor for Stephanie, like she's doing. So we're going to let's do the lateral. So let's go ahead and look at where the muscle attaches here on the greater trochanter. It comes down here to the lateral knee.
Oh, we switched from QL to...
Oh no, did I say QL? I was
No.
thinking rectus.
Oh.
You said vastus lateralis.
And yeah, so and vastus. So right
No,
now
I
it's
thought it was
I'm on
QL.
vastus, and
Sorry, my
then I'm
bad.
going to do rectus.
Okay, my bad. Okay. Vastus lateralis.
Keep up with us, Justin.
Oh, please. I was just ahead. That's
So here we're looking. This is our
wait up for us.
So we're
Okay, wait up.
we're looking right through on the side of the leg and on the front. So first we're doing the side. So we're looking for painful spots, and we're using the jack knobber, and also we're using the back knobber.
How long do you hold the point?
So we're looking for a painful spot.
But how long do you hold it?
Once you find it, two or more breaths. But if I don't find one, I might just go quickly. Go, oh, I don't feel anything. Oh, go to the next one. No, nothing there. Oh, maybe I'll move to the next one. So I'm looking around, looking for a painful spot. So I'd have to,
Everywhere I go is a painful
That's
spot.
right.
I'd have to put more pressure on to feel a painful
Well,
spot.
if everywhere you go has a painful spot,
Yeah.
Sharon might suggest otherwise.
So-
but that's why
so-
I like the foam roller, because it
Yeah.
gets such a broad region at once.
Yeah, so I'll do my other leg. We'll do on the foam roller. That's good. So then next we're going to take a look at the rectus femoris. So it attaches here at the kneecap. It
Yep.
comes all the way up, all the way up, all the way up, all the way up.
And
up,
doesn't
up,
it get
up
a
to here.
nasty trigger point right at the top? At the
Oh, right
insertion?
here, right at the top,
there?
right there. Yeah. So
The origin?
this is our one of our main trigger points. It's
Oh,
just
yeah.
below. So you find it the lesser trochanter come
Or,
from there.
Anterior iliac spine.
Yeah.
ASI.
So go to the anterior iliac spine,
The as is.
and then we're going to go just below it and press right there, and that's going to be our trigger point right there.
Oh yeah.
She found it.
You found
And
it.
this causes significant knee pain right there.
Now
Significant knee
what
pain.
do you say when
Do it on
somebody
the
has
other
a
side.
very painful spot? Do you say, ouch, that's painful?
No, what we want to do is we want to really, so our idea is that we want to have full function and
Yeah.
full use of all the muscles, and all of the muscles shouldn't be painful when you press on them,
Yes.
and we should have all the nerves working, all the muscles working, and all the joints having full function. So that'd be a nice goal.
Yeah.
And then so we're starting out with getting the muscles to be more functional,
Yeah.
and then we're going to see if we can't get them to pass the range of motion tests.
You
If
see,
you
and
can
that's
pass the range of motion
exactly-
tests, we're most likely going to be pain-free and full function.
That's exactly how you want to talk to your patients. If you take that last clip of video, the last 10 seconds of what Sharon just said, write that down, memorize that, make sure that's how you talk to your patients. Sharon will say, oh, you noticed that there. Now, we want that muscle tissue not to be painful when we push on it. Healthy muscle tissue is not painful when we push on it, so we're going to work all those painful chemicals out and release those taut bands so that when you push on it, it's not painful, okay?
Yes, so
Yeah,
that's what we're looking for.
Yep, that's our goal.
Okay, and we can massage with the tool a little bit.
Mm-hmm.
Now, so this was good. So let's go ahead and let's try another way of treating it too. So I'm going to go ahead and do it on the floor. And a good way to do it is, if you can, with a stretching strap. So
Ooh, yeah.
you can for getting some of the work done. So Stephanie, if you could hand me the stretching strap, and I'll use that again. So let's go ahead and do your other leg. So let's come along the side. So for that, you can come this way, and we're gonna look for painful spots right on the outside, looking for painful spots on the vastus lateralis.
There's some great pictures of that in here too. Oops.
So this is the more athletic way though, because look you have to hold your body up. And your hands, you have to use your hands. So this is good, but you have to be able to use your hands and take all your body weight on your hands.
Yeah. So you do
Yeah.
have to be a little stronger
Yeah, a
to do
little
it this
stronger.
way.
Yeah, a little bit
Could you
stronger.
put like a pillow or a foam mat or something?
Yeah, that's what you can do. Is you could have a blanket and pillows, and you could use those and hold yourself up, and then just hold yourself. So you can definitely do stuff in your bed on a soft surface.
Yeah.
Yeah.
And there are rollers that, of course, are not that thick in diameter
Yeah,
too.
this is a thick one.
Especially thick. I don't think it gets any thicker than that one.
Yeah,
so.
this is a thick one.
Yeah. So.
So and then while you're doing it, so that we can also do our quad. So let's do the left quad as well.
Oh yeah.
So here you can look around for painful spots in the quad here, and that's good. So this is a good way to do it. And looking around all over, and a little bit lateral. Look for a painful spot. When you find it, you're going to hold it for several breaths. 2 is good. More is okay. But then another way to do it is to also stretch it at the same time. So you can put your stretching strap on your foot.
So you want to go over these, just like we're doing right now. You want to go over these with your patient and make sure the patient knows and can complete the protocol that you're sending them home with. You want to do it with them so that they can feel comfortable. Make sure they don't leave your office, without knowing how to do this.
Yeah. So you can go ahead and stretch it and treat it at the same time. So this is a really good way of getting all the trigger points and stretching them. You could encourage the stretch at the same time. So this is a really great way to treat them.
Yeah.
So that's our rectus femoris. So let's go ahead, let's measure Who would like? Stephanie.
Yeah.
Let's do Stephanie.
Yeah. Remember what
Okay,
sets
go ahead
the
and lay on your
masters
tummy.
apart from the regular people is doing it on the stretch, perpetuating factors, and
So
those
for
are two big
rectus
things.
femoris, your goal is to see if you can get your heel to your seat. Oh, that's pretty good.
She's doing great, huh?
3 fingers. That's 3 fingers.
Stephanie is doing great these
3
days.
fingers. Okay, so you're just looking for it to be a little teensy bit better.
Yeah,
Okay.
excellent.
So she'd be really pain-free if her knees and thighs, if she was. So again, about 3 fingers.
Mm-hmm.
So so that's our goal, is to get your heel to your seat. Now we can do it seated and laying down and standing. Let's try it standing. So, so for this, you can grab onto your foot, or you can have your stretching strap, and then you get your heel to your seat, and then also you can get you can take it back a little further, continuing to get your heel to your seat. So good. So your goal would be to get it to go back further. Yeah. Good. Let's see the other side. Yep, that's good.
I have the same problem on the left.
Oh, good. Okay, I like how you do it.
These things finally come in handy for something.
So you resist. Now go ahead, stay there, Camille, or anyone. Go ahead and do with your stretch. Okay, grab. Okay, so you're gonna pull it back. Now push and resist away, and then bring it closer to your heel, your seat.
Yeah, this hurts too much.
Oh, it hurts too much. Okay.
No, it hurts where I'm holding it.
Okay, so our goal would be
Yeah,
to get
where I'm holding it.
to get your leg further back. You know, so get your thigh further back, and with the thigh further back, get your heel to your seat.
Yeah.
Okay.
Sharon, what if they don't pass these tests, but they're not really having a lot of pain? How did you tell the
but
patient
we're
that?
trying to have full function.
Yeah.
Okay, so the idea would be this way you're going to be really strong, and then you're not going to be in danger of having a knee dysfunction. You know, so this is going to keep your knees in good shape, and it keeps you from needing surgeries or needing interventions of any kind.
Sharon says there's basically 3 ways to approach a patient. One is to treat a condition, one is to treat their pain, and the other is to treat their function.
That's right.
And when she gets them out of pain, she oftentimes says, well, let's
have
go to
full
function now.
Let's
Yeah.
have full function. What if we could have full function of
Right.
our whole body?
That's why the name of the clinic is pain-free and full function.
That's it. That's it.
So
That's it.
never feel
Go
afraid.
somewhere.
Yeah, never feel afraid to recommend that they go for full function, even if their symptoms have relieved.
Right.
Sometimes symptoms are the last thing to come and the first thing to go. Function and dysfunction are also really important.
So I love getting my muscles to be having full function. So
Kirk Smith says, that sounds familiar to me. You've heard her say that.
He's heard me say that before. Yeah. So, but then then a lot of times after I help people with eliminating their pain, then I like to go from different sport to whatever sport they like to do, or whatever they want to do with their body, and see if we can't do what they want to do and still have full function and still be pain-free.
That's right. Achieving goals is another way
Yeah.
to approach
So that's
patient.
so another direction to go into.
And
Yeah.
think about this. This is what this Mastercourse is giving you. You can treat function now. You can treat goals, athletic goals of any kind. I mean, just think. If you're a tennis player, think of the muscles that you'd want full range of motion and full function of. If you're a golf player, you probably every head to toe. If you're a golf player, pretty much most sports. So think about that. All the things you can do now.
Super.
Yeah, super.
Okay, so we got a few goals, right?
Yeah.
Yes.
We got a few goals. We got a few things to do. Great.
No one leaves with an arrogant smile.
Okay, so usually after we do our self-care, then we do some range of motion.
Oh, yeah.
So do you think we might be able to put some music on?
Shall I give it a shot?
Yeah, well, no. So
Stephanie's
how about
better?
Stephanie?
Stephanie's better at finding music for that.
She can help us with music.
I always put that Metallica gangbanging stuff on, headbanging.
Headbanging.
Gangbanging. I got a tongue of headbanging.
Headbang. Yeah, not gangbang. We don't
See,
gangbang.
I don't know what any of that means. I have no idea.
No rap music.
No rap music. Yeah, that's what I was thinking of. That's what I meant.
It could have a good beat.
Yeah.
Yeah.
Yeah, it could.
We'll have
Yeah, it could have a good beat. I get a little
It's
louder.
a little mellow.
Just louder, it's fine. Louder, louder. Good. Okay, so let's do a little bit for the QL. But you know, we didn't have the QL on this one, Justin. Yes, we did. Yes, we did.
Yeah, it is on there.
Yeah.
Let's do the QL. Okay, here we go. All right, so here, yes, oh, good. Oh, you're good at this.
There you go.
Yeah, there's something that doesn't hurt.
Okay, pelvis forward. Louder, louder. Forward and back. Forward and back. Good. So that's our QL. Good. Okay, so we're going to look at our gluteus minimus and medius. We're going to put our foot in front. We're going to in and out. And in and out. Double time. And in, out, in, out, in, out. Other side. In and out. In and out. Step in and out. Double time. In, out, in, out, in, out, in, out. Good. Another good exercise for this one. Let's all turn to the right. We're gonna turn. So you lead us this way. We're gonna go walk sideways. I'll lead.
Yeah, I'll lead.
All right.
Oh, that way.
Yep, they're fine. So we're going sideways, and let's cross over. That gets our gluteus minimus and medius.
Grapevine.
Grapevine. Let's grapevine the other way. Here we go. So get this in when you go from room to room.
Yeah, you can do this, yeah.
Walk like this when you go from room to room. You just walk your toes in, toes out.
Walk like a trigger point therapist.
Right? Great. Okay, so let's do another one for the QL. So we're going to go like this. Let's put our elbow down and up and over. And down and over. And down. Other side. And down and over. And down and over. Down, over, and down. Okay, we're going to take a look at our glute max. Lift and lift. And lift. 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 Let's take it lift and then take it back. So for balance.
Get out of the way. Yeah. Hold on to it.
Yeah, good, good. Hang on to the wall there. Okay. So we're going to glute max lift and back. And lift and back. And lift and back. Other side. And lift and back. And lift and back. And then we're going to do this. We can do this. Take big steps. So this is, go ahead. We're going to walk. Take big steps. And back. Let's go ahead backwards. Big steps. Back. Back.
Teaching us how to walk all over again.
See, Periscope's great. We're all in one big room, aren't we?
Okay, how about for our vastus lateralis and our knee fixing muscles? Okay, so let's go ahead and bring our heel to our seat,
Yeah.
and bring our knee to our chest. Bring our heel to our seat. Bring our knee to our chest. Bring our heel to our seat. Bring our knee to our chest. Bring our heel to our seat. Other side. So bring your knee to our chest. Bring our heel to our seat. Forward. Bring it back. And forward. And back. And forward. And back. Good. Let's kick our butt. Kick.
Who knew you could do it to yourself? Usually everybody else is doing it to you.
Oh, kick other butt.
That's kick your other butt, not someone else's.
Oh, that one I can reach.
That's
Wow.
the vastus lateralis.
Vastus lateralis, yeah. Wow. Still your own butt. But.
That one I can catch. Wow.
Wow.
Good.
Good. Okay, walk. And toes in. out. And in. And out. Okay, one area that we did look at was supersensitive spinal segments.
No, we didn't do that yet.
So that would be our that would be the L2 to S3 or S2 or 3. So how can we assess for that?
And you can get that while you're doing your QL real easily too.
Well, we were already. So here we're going to take a look at our
yes.
let's see.
Should I dim the music or not yet?
Well, we could kill the music. Yes.
Okay. Yes, supersensitive spinal segments.
Okay, so we're not lifting up the skin here too good, Camille. Okay.
Tight.
And over here, so a little higher here and a little lower here. So about so you're a little bit too tight there, and look over the sacrum.
You guys getting comfortable with the explanation of this physiology?
Let me take a look at you, Linda. Okay, so here it's good. Oh, good. But about L5, too tight. About L5, S1. So here, good. Again, L4, L5, S1. So that's a little tight there. Let's take a look at you.
Again, when there's nerve entrapment at the spinal root, it causes hypertonicity of the muscles in the skin overlying the spinal segment.
Yes, but it also causes heightened tone in all the muscles that the nerve distributes to.
Yes, exactly.
So here for Stephanie, so we're pretty good here, but again here L5, S1 is pretty tight, and S2, S3, all your S's. Okay, so here, so a little bit L4, L5, in your S's. So for her, so why don't we treat those muscles and see what we can do? Okay.
In my office, I had a $2,000 machine. It was a Surface EMG, but this is exactly the same thing. It does the exact same thing. Yeah.
Okay, so
EMG fingers.
EMG fingers.
So we're going to use some little teeny balls, okay, to get right into that area, or for you, the little bit bigger ball. Okay. And here we go. So here for you, the little. Oh, you got it. She's got a pinky. Here you get a little one. Okay. Stephanie, okay, go ahead and try that. Okay, so one thing we could do. Let me show on Stephanie. So we can go right on, find the spine, come just to the side of it. So find the spinous process, come just to the side of it, and you're gonna press right in there towards the spinous process, straight in, and towards the transverse process, and go down and up like that. Then move down. So we're gonna go towards the spine, away from the spine, press between, and a little down, a little up, and you see if it's already a little better. Okay. There you go. Just we're not pressing very much there. Okay. So go ahead and try that on the wall.
I was pressing too hard.
Go ahead. It got better from pressing lightly. So that was good. Okay, so let's go ahead, and you can also do it with our back knobber. So some of us could use our back knobber, some could use little balls. So here we go. So we're going to go, let's start at about L4. So here's L5, so let's go a little higher up to L4. And let's look right there for some painful spots. And one way to treat it is like I am, is like pressing on it while I'm moving it. That could be good, so go down a little bit lower on the left side. Now I'm right on the sacrum, and I'm right on the rotatories and the multipides there, and come down a little lower. And I'm making sure those muscles can work. So I'm shortening them, lengthening them, shortening them, lengthening them, shortening them, looking for painful spots. When I find a painful spot, I'll hold it. So let's go, I'm going to go to the other side now. So this is called a big bend. And I'll just take off my jacket so you see where I'm at a little better. So this is a nice tool. I like it because it's steel. Okay, well, I was doing this side. Okay. So I like to, wait, reaches all the way around the body like that.
Oh yeah.
So here's L5, and let's go up to L4. Let's find the spinous process. I'm going to press in and stretch it and go towards the transverse. Press in. And I'm feeling, everything's working. It's working good.
Good.
Okay, now I can find maybe a couple fibers that could use a little attention.
Each little spinal segment is supposed to move independently.
Yeah, they're all supposed to move.
That's 27 little tiny segments that move independently.
Yeah, so looking for painful spots. So I can feel I got a couple hard muscles in there. Mostly it was not painful. Okay, so that's good. So let's go ahead then afterwards we're going to move it. So we're going to do little pelvic tilts. Okay, so we're going to do pelvis forward, pelvis back, pelvis forward. So you bend your knees, pelvis
with
forward.
the ball?
No. Oh, no, without, no.
Oh, okay. I'm like, I don't know if I can do that one.
So forward and back, forward and back. And then we're going to side, 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 side. Yep, we're doing that. Forward and back. But now let's do diagonal. Forward to the right, back into the left. Forward right, back left. Forward right, back left. Let's do it the other way. Forward left, back right. Forward left, back right. But now, because I'm trying to get this in every day, this is what I do. I get it in when I walk. So I do pelvis forward, back, while I'm walking. And I get it right in and I go side, side.
Do you have a parade following you?
Sometimes. Mostly pigeons and penguins. But,
Little kids.
yeah, little kids,
So I get
pigeons and
that movement
penguins.
in. So a lot of times I get up and they're, oh, it's a little tight, and I get it in. I move around while I'm. So that's usually what I recommend is getting it in all day long.
All right. So,
Okay, let's take a little break, and when we come back,
let's take a little break.
I'm going to show how you could treat each other,
And
or a
just
therapist how you could treat your patients.
so let's just think for a minute. If you're getting good at this, you should be able to say gluteus minimus. What do I need to know? I need to know its referred pain pattern. I need to know its innervations, maybe at least loosely, or how to find it quickly. I need to know the range of motion test for it. I need to know where it is and how to palpate it. And I need to know the self-care for it. So you should be able to go through each of these muscles and say, I know the range of motion exercise to do. I know the self-care. I know the innervations. I know the range of motion test to perform. I know how to palpate it and do the compression. And when you've got that, then you know, and I know the referred pain pattern, what it looks like. That's what you need to know for every one of these muscles. All right, break time.
Okay, see you in a couple.
See you in 10 at exactly 7:30.
Okay, you could give us a little music. Some carrot juice. It's hard. So the veins would be sore, so you're going to feel. And it's feel functional or being dysfunctional. So you want to keep moving when it's sore. Oh, yeah, you do that. Yeah. So it's good. Maybe you don't try to create too much soreness, but if you don't know how to fix it, but it's best. Like one day, I finished working at 6 o'clock, and I was just my last patient. I did something, and I caused myself to get frozen shoulder. It was like I couldn't believe it. One of the other therapists was there, and I said, "Man, you better treat this. I got work tomorrow morning at 9 o'clock, and I'm not going to even use my arm. I can't even use it." So she started treating me. 3 hours later, she was still fixing it, and we got it full function. But if you treat one thing for 3 hours, it's going to be pretty sore, right? So I knew it though. But I never treat patients that way, because if we do, then they're going to be really mad because they're going to be too sore, okay? Because they don't know what to do with it. But I knew, keep moving, put heat on it, keep moving, and it was gone. Like I've never even had a twinge or anything, nothing for like 10 years.
What about icing?
Icing is only useful if it takes away the pain. It's not useful.
Because I have a client that loves icing.
I don't recommend her icing, but you know what? If it works, you could certainly be observant of that. But many of my people who've been icing their tissue gets really hard from using too much ice. It's all hard from that. So it could be, but they like it. Maybe there's some use.
I think it relieves some pain. That's why.
Well, if ice is getting rid of your pain, well, where does she put these? Where does she put these?
And then I put on something.
Well, first, it's the best time to use is when it first happens. They'll just that hormone. So painful. Put in the ice. That's the absolute best time.
Well, my friend who's not a client who has like chronic nerve pain, and she goes to sleep with ice packs, and she thinks that she has sciatica, but she keeps on pointing and massaging in here.
Okay, so then how do you get people who have that dysfunctional to be functional? I'm just saying, that's what, so they start.
I mean,
there.
is she making herself worse with the ice? Should she be
I
using
think
heat?
I'd just start where she is. I'd stay with where she is for sure. But
And sciatica doesn't come in the front.
but she's
Is this
got
a
pelvic floor.
What's it called? The
This is pain. This is headache in the pelvis. So this is.
She keeps on pointing and massaging
Yes,
this area
yes.
by her groin and almost by.
Yeah, so that's what causes that. That's one of our next classes coming on.
And then she said that it goes down to her feet. It goes down into her legs. It goes down into her feet. And then once the nerve pain starts, everything lights up. You know, it starts in her neck. And yeah, she's very dysfunctional.
Well, I'd stay with the ice until you got to where she was at that dysfunction. But that would be okay for a short. But then you would say to her, listen, as we get better, you probably like to. So just like this, she can.
So this is pelvic floor
Yeah.
that she's.
Yeah, yes, that's
And she's calling it sciatica.
yes, she is, but it's close to the hamstrings. That's close, so I can understand why she's
So should she be treating the trigger points in the pelvic floor? Can you get at them?
But the thing is the muscles that refer to the pelvic floor are close to the floor. So that'd be all the muscles that we're treating today.
Yeah, the ones that we're doing today, all
And all the spinal roots, all the glutes, the glute max, the glute pillars, the medius, all the deep lateral rotators. They're pressing everything that goes down to the pelvic. So it's pressing, so they're the pure.
I'm not exactly sure how you get to the deep pelvic rotators.
We just did it.
You just did it?
Yes, we just did
Okay.
it. We just did it.
Oh, okay. So you can't get at them like on the table. You can't do table treatment.
Your elbow is one of those.
Okay, so let's see what we want to do.
I must have done something right. She regained functioning. The other client, you know, that was the friend that I'm trying to, you know,
Sure.
give her some advice.
She improved, right?
Well, yeah, she was having numbness, she was having tingling, she was starting to drop things. Oops. And then when I would treat her, she would say, "Oh, I'm getting these tingles. I'm getting these tingles in my hands." And I said, "Well, it's okay. Let's keep on, you know, because her whole arm and also the cervicals were just embedded with trigger points, like her whole arm, you know. And then even like when I would work on her hand, just doing massage on her hand, but all of this numbness and tingling and dysfunction and dropping things and weakness subsided. But after I would do the trigger point, she wanted to put ice on it for the soreness.
Well, I don't usually recommend that, but it could work for some people sometimes. And it seemed to work, you said. With some success.
Well, she requested it, and then she said, "Oh, yeah, this is wonderful." She wants to lay on ice. She wants to put ice on her, you know, on her neck too. You know,
Well,
I mean, I think of it more for injury.
sure.
You know,
I think injury would be the ideal thing.
and that's why.
Sure.
Good. Use every one. Good class. Good class. It's nice to have some big muscles to work on, right? that do self-care on big muscles.
Treat something we don't need to treat.
Sit on it, sit on it.
Yeah. You guys don't have to be masters of it, but it's nice to see, again, something someone else might be doing. You know, someone that you might want to... Totally. Yeah, and it's also good to know what you're achieving with your manual therapy. I mean, when you're working on an origin insertion, isn't that nice to know that you're actually affecting the nerve function of that muscle? You know, that's really good. So here's your neuromuscular junctions. That's where the trigger points are found that cause referred pain. But here at the ends of the muscle, down here and down here, those are where, when muscles are injured, they get torn or they're weak and you can't recover from an injury. That's where when those fibers get injured here, that's when a muscle won't regain its strength after an injury. That's where you need to treat there. So, okay.
Because they're not firing. It's
Yes.
like turned off. It's like switched off.
Like a light switch. And
I've had so many injuries. I think that's the
exactly
problem. That
when you
things
had
are switched off in me.
That's right.
And then when I start to treat these things, it's like my whole body's a trigger point, one big trigger point.
That's exactly right.
I mean, that's what it feels like. It feels like it.
Exactly right. Because when you get a weak muscle, especially if you get a weak hip muscle, then your low back has to work to swing your hip around every step you take, and then that just tightens all the way up. I mean, that's why I'm just gonna show you hip compaction, but adequately treating with trigger point therapy will clear all this out anyway, but it's just kind of neat to know that you're actually doing this. And then if you specifically intend on doing it, of course, that even makes you better at it.
What about tendon laxity?
Tendon laxity...
we don't have that much of it, but we can treat it and let's see if it gets better. If not, we may want to do something that makes the tendon better. There could be some...
Yeah, I don't usually find it too much.
You don't find... Yeah, you don't... But
sometimes I literally feel like the bone is slipping out of place. And that's another thing that hasn't happened as much since I've been wearing these inner soles.
On a particular tendon like that, and then we can make that one hard.
But a lot of times it's muscular imbalance. One muscle's pulling too hard on the other, and so it's making it slip out when it's moving. You know.
Yeah, it's very painful. It just like oh my god, it feels. But it's probably a tendon. So.
Yeah.
All right, me on.
You're on.
Yeah. So should we take a look at your
Okay. It's the first offer I've had today.
Okay, everybody, we're back.
I had an improv class before I came here, so
I'm there all the time.
I'm a born ham.
Okay, so we're gonna take a look at Linda. We're gonna see what we notice about her gluteus minimus and medius and her QL. Well, let's take a look at you without your shoes. That's good. That'll be great. Super.
Also, we should repeat the question. Linda asked a great question at break. She asked, what happens if you treat a muscle and it gets sore? Can you over-treat a muscle, and is soreness, what do you do? You know?
Well, if you over-treat and it gets sore, that's your opportunity for it to heal fully functional.
Yeah.
So sometimes you maybe overuse your body in some way, and sometimes you might over-treat something. It's not very common, but you might. And if it does, it's an opportunity to heal fully functional. So what you want to do is keep moving, keep using, keep massaging, and keep putting heat on it, keep using it, and see if you can't heal fully functional.
That's right. So what she's saying is that over-treating in soreness means that you've got a little bit of a healing crisis inflammation process that started. But that is an opportunity. That means the tissue can change while it's in that healing mode. In a sore healing mode, a muscle can heal and change its function. So Sharon is saying that is when you want to make sure that you're using heat and you're keeping the full range of muscle, that it heals long and flexible.
So we're going to check her gluteus maximus, and we see that her her knee to the armpit test. She's
I'm not going to pass that.
She's not passing it right this second.
this lifetime.
You just put her to the challenge.
9.5 inches. We're going towards the opposite shoulder. So it'd be 9 inches if I push a little harder there. So
do you hear that, Sharon? Not in this lifetime. She's
not in this lifetime.
I shouldn't have said that.
Okay, so 10 inches here, so it's a little tight there. You can feel that, right?
Oh yeah, very much.
So that's your a little bit your gluteus max, and also maybe a couple of other muscles. Okay.
My left is my whole injured side. Where,
oh yeah.
You know.
So here we're also going to check your gluteus medius minimus, and we'll see what. So here we can see that you're going to rotate to about.
Not as bad.
No,
though.
not so bad. 3 inches.
All, really.
3 inches. No, that's really good. She's doing good. She's doing good. And then
A
here.
little bit worse on this side.
So this is 3 inches. Okay, so
bad.
3 inches and 3 inches. Good. Okay, so we're going to take a look at a few muscles. Let's take a look at you. Let's have you sit up for a minute and then stand up, and I'm going to have you lay sideways. So just turn to the side and sit up. I just tested you a little bit, then I was going to have you lay sideways, but I'm going to put something underneath you. So you probably need to scoot down just a little. Okay.
Sharon's famous side lying posture.
This is it. Okay. So go ahead and lay sideways. Put your shoulder here. Oh, she doesn't know what I want her to do.
Facing which way?
So better to face that way.
Okay.
Yeah. Okay, good.
So when someone gets sore, you say, oh, good, this is an opportunity for you to heal fully functional. So keep it warm and lengthened.
Now, maybe we don't want to get so sore,
No,
because then we know that
sometimes patients complain about that.
But it is an opportunity. So how about if you overuse in some other way, then it's your opportunity again. Yeah. So here, let's go ahead and look at our QL. So we're going to stretch our QL. So we're going to push our rib cage. We're going to push our rib cage up and pull our hip down. And so here's our QL. So it's right here. So it attaches onto the ribs and onto the ilium, and it's this shape like this. So we're going to press in like this. Then we're going to press in like this. Then we're going to press in like that. Then we're going to go towards the attachment, then go towards the attachment.
Right, you see this? She's treating it on the stretch. Like I said, that is the difference between a master and a regular body worker.
What do you think?
Yeah, that's okay.
About to there? About right?
Yeah.
Okay. So now I'm going to hold it there. Now I'm going to go a little forward and pull back. Now I'm going to go a little back and pull forward.
Treat on the stretch, guys. Treat on the stretch. It's so crucial.
Okay, so I'm going to take, so that's a little bit of treatment on the QL, so we might do a lot more. But so right now we're going to take a little bit off the stretch. So now we're going to take a look for the gluteus minimus and the gluteus medius. So the medius is not part of our program today because it doesn't go down to the lateral thigh. But here you would find for the medius, you would find the ilium, come down about 2 fingers, press in and up towards there. That would be getting your gluteus medius right there like that. But to get our TFL, which is right here, we're going to go ahead.
Oh, that's too much.
We're going to take a look at it. We didn't touch it too much there, but she noticed it. Yeah. So here, this is it right here. So you're going to find the front part of the ilium, and then you're going to come just a little bit here, and you're going to just go ahead and press in and towards the front of the ilium. What do you think of that? So
no comment.
So we're using like a broad pressure. Kind of moving it forward.
That's really. Yeah, that's tender there.
You notice that, yeah?
Yeah.
By changing the bend in your elbow, you can affect the width of your contact. Like that.
So we're going to find
that's a broad
we're going to find the
like
gluteus minimus, okay? So here, we're going to find the greater trochanter. Then we come up about 2 fingers, and we're going to use our forearm, press in, and then towards the greater trochanter. What do you think of that?
Yeah.
So there, we're treating it a little bit. Coming this way and treating it right there. So that's how we'd be treating. So this would be our minimus coming like this. This is our medius would be coming like that.
So you go up for the medius?
Yes, that's correct.
Up.
Yeah, so for the up
and
like
down
this.
for the minimus.
That's right. That's right. Towards the greater trochanter for the minimus, towards the top of the ilium for the medius.
Awesome.
Okay. Then we're going to take a look at the vastus lateralis, and it comes here, and it goes right to your kneecap, and it comes like this, and that's our vastus lateralis. And let's take a look for a moment and see the movement of your kneecap. That'd be fun.
Do I need to turn over for that?
If you would, but you could lay right on my little pillows.
Okay.
Yeah, so it'd be fun. Just lay on them.
Oh,
yeah,
yes.
they're kind of fun, right? Yeah, see, that's comfy, right?
Yeah, that's
okay.
a good one.
Okay, so here we're going to take a look. So we want to see, does the kneecap go down? And it goes down a little bit. That's good. Does the kneecap go side to side? Pretty good. Yes, doing that pretty good. So it's moving pretty well. So that's one test for these muscles.
One test for vastus lateralis.
Yeah, so one test is it holding on to it so much that it won't let it move, and it's letting it move. That's good.
Also
okay.
the intermedius and the other quads as well.
Yeah,
yes.
So this one you can do gentle because this one I fell on.
Oh, this one you fell on. Okay.
Not the one that you're doing, but the other one.
Yeah, the other. Yeah. So then one more thing for the intermedius, we're going to go to all four corners of the patella, and we're seeing, can we turn it? And you see we can't turn it too much. Okay, so but we're turning it a little bit. Yeah. So if we get, that's the deepest one, the intermedius here. So that one there might be a good one for us.
I felt the tingling in my toe when you tried to turn it.
Oh, that's it. Okay, so let's see if we might look at that one. Okay, let's look on this side. So this is the one where we had some injury, so it might be a little different. Okay.
Yeah.
So let's go outward and inward. It's going, it's moving. Down, oh, it doesn't want to go down as well. I can feel that, yeah. So it stays up a little more. And let's do the twisting. So it doesn't like the twist. Yeah. So
it's kind of stuck.
Little stuck. Yeah, stuck patella.
Stuck patella.
Or we might call that chondromalacia patella.
Yeah.
Okay. So sometimes we might call it that, yeah. So we have some little
post-injury trigger points.
Oh,
yeah.
Post-injury trigger points. Yes. Okay. Yeah. Lots of things we can call them. So another test we're going to do for the quads is, can we bring our heel to our seat? Okay. So we're going to see if we can do that and how close we can get. So we'll see it on this one, and then we'll look at it in that one. Okay. So if you come to the class in person, then you might get treated, and everyone might get benefit from that. Yeah.
Yeah, I'm a good case. I'm a good case study. I'm a piece of work.
Okay, so we're measuring from the heel to the ischial tuberosity.
Yeah.
Okay, so here, that's 8 inches. Okay, so let's do
What's
the other one.
What's it supposed to be?
Heel to the seat.
Oh, yeah, okay. I won't say not in this lifetime, but just not tonight. Not tonight.
Not today.
So what if we got maybe 1 inch better? That'd be good. Or 2 inches, that'd be great. So that's good. So if we improve a couple inches, that might be the meaning.
Yeah, I have to review what I have to practice.
Yeah, so here again, we're going to test. So here we're going to put right to our heel.
Oh yeah, you can see how that just
right
doesn't
to the
want to
heel.
go.
And then we're going to come right to the sit bone. And then you can see if you're having some improvement there. So the sit bone right there. Oh, this is 7. So this one was 8, and the injured one is 7. So hey. Okay, so that's good. So we did pretty good. So that's one test, and then another test is laying on your tummy and then having your heel come to your seat that way. Can we try that?
Sure.
Okay.
Same thing. Or?
Okay, go ahead and lay on your tummy. Okay, so here we can go. So for the vastus, we can come towards the opposite sit bone and see where we are there to the opposite sit bone. So that's 5 inches, and then to the same sit bone. And this is the more injured one, 5 inches, and the less injured one, right?
Yeah. What is it?
Okay,
Tighter?
this is you're better this way. So this is 5 inches here, and to the opposite one is 5 inches. So pretty good, pretty good. So it wouldn't take maybe too much to get a little bit closer to your seat. So it's not too bad, not too bad.
You're not kicking your own butt enough.
Okay, so let's take a look at treating your vastus lateralis on the sides line. So I'm going to treat you. So let's have you come up on your hands and knees for just a little second. All right, so let's put your shoulder in the little crevice.
Oh, on the side again?
Mm-hmm.
Okay.
Okay, super. And then I'm going to give your head a little pillow. here it is.
Are you guys starting to imagine how she might treat the vastus, knowing that, you know?
Oh, you knew what I was going to do.
You're going to do something on the stretch, right? Of course.
How did Justin know? Okay.
It's really tight in here.
Yes.
Front.
So that'd be our
intermedius
and our
and a rectus femoris, maybe.
Right, a rectus.
Rectus
So we could,
femoris.
right. So we can treat the rectus.
Rectus femoris.
Just grunting.
So we can treat it while we're stretching it.
Yeah.
Okay. So here, so we can do pincer compression on it. This would be one way of doing it. So do a nice while we're stretching it, and then also we're going to do our vastus right here. So we can do that. How's that positioning of it right here? Do you notice anything here?
Not yet.
Okay.
But I'm sure I will.
So here we can go ahead and treat while we're stretching.
Well, this is interesting. I'm not feeling it.
Yeah, isn't that great?
What happened?
Well, what can you say? She's improving.
I'm feeling that.
Okay. So here we go. So we're pressing and looking for taut bands and giving him a little stretch. So go ahead and press your foot towards me a little bit and relax. And push towards me and relax. Okay, so I feel some really hard spots right here. Yeah. Push towards me and relax. Good. Push towards me and relax. Good. And push and relax. Good. And push. Great. Push. Super. And push. So this is a good way. And right now we're at 2 fingers. So that's better than before. So that's, we had kind of probably 5, I think it was closer to
5 inches.
5 and
With 5
little,
inches.
5 and, but when we were in this position, it was anyway. It was,
was
5 or
inches.
more.
Yeah,
And so here's pretty good. So that's nice. So that's an improvement. So I'd like to get at least the 3rd improvement, and that was at least the 3rd improvement. That was really good. So that was really great. So let's take a look at the other side. Let's go ahead and look at the more painful side.
And it actually feels like it's fatigued in here. I can't describe it. Is it because something's being released?
Yeah, so sometimes, let's go ahead and, you can have a lot of different feelings, but you notice it feels kind of like a fatigue feeling.
Yeah.
Okay, so on this
After
side,
the treatment, you're saying?
so take a look on this side again. We're going to look at
Now this is the side where they said that I have bursitis. So this
said
one's
you
going to
had
be.
bursitis. This is
That's the one where they said I had bursitis in my hip, which I don't know
okay.
if
So
it really is or
so
if it's
what muscle?
So you can go easier on this side.
Okay, yes. So what muscle might cause greater trochanter bursitis?
The bursa muscle.
The bursa muscle. That's it.
You invented an muscle.
The tensor fascial lata.
Oh, yeah.
Okay,
Oh gosh, I need a drink. Tension fascial.
The tensor bursa lata.
That's right there. So it's right here, right here. This is where the muscle is, right here. So we'll take a look at that in a minute. And remember that the tensor fascial lata is L4S1. So let's take a look here at L4S1. Oh, nice. Feels nice.
You mean the nerve intervention?
Yeah, well, it would be the rotatories and the multivities that would be affecting the nerve compression.
Yeah, I felt something just above.
Yeah, right there. Okay.
Yeah, right there. You
Right
got
there.
it.
Yeah. So I'm looking right there to see if I might affect this here.
She said she felt a little fatigue in the muscle after treating it. What could that be? What gives us that fatigue feeling in a muscle?
Well, a lot of times
Lactic acid.
A lot of times when a muscle wakes up, it could have a lot of different feelings.
Well, it could be releasing some lactic acid and things when you're working on it too. Some of those same chemicals get released.
So we're right here. So here again, when we're doing the TFL, we're going to press in and towards the brim of the pelvis here. So we're pressing this way. So we're going to go here. I'm going to look around.
Yeah, that one, that's a killer. That's burning.
So burning. So when we're looking for the burning spots. And that's going to be the spot that's really going to help the greater trochanter bursitis. What appears to be greater trochanter.
You mean you don't
bursitis.
avoid the burning spot?
You go right into the burning spot.
Go into the ring of fire.
Yeah. Elbow into the fire, folks.
Okay, so here we get just a little bit of.
You got like a little chihuahua reaction there. That's an interesting jump response. So,
Yes. So here, let's take a look at our gluteus medius. So, and here's our, again, remember the medius is right here, and it could cause you to have like low back pain, and it could cause hip pain, but it doesn't come down into the area of 21. So that's why we're treating the gluteus minimus, which does come there.
Yeah.
So here we have the gluteus minimus. Here's our greater trochanter. So let's come just up from it. So we're going to come up from about there. So we're going to press. So we're using like the broad part of our forearm, pressing in and towards the greater trochanter. What do you think, Linda?
Yeah.
She notices it. She notices
it's
this.
registering, yes.
Yes. This is the more painful side. So, right?
That doesn't hurt. Well,
It doesn't hurt too much. Good, good, not too much. Super.
That's good.
And then we're going to also look at her QL on this side as well. So again, for the QL, we're going to treat that on the stretch. So we're going to take this down, take this one up. So we're not treating you today. Yeah.
Stephanie's hiding outside the room.
Yeah. Okay, so it attaches onto the rib cage and then onto the ilium. So we're going to take a look here. Remember, it's this. It has this shape like this. To this. This is like where the spine is. This is where it would be right here. And we're going to press right onto the edge of it, and then get into this side of it, and then that side of it.
Remember what I said, guys, last week? That to stretch a muscle, you line the fibers up so that if there's a muscle that's got a twist in it, you straighten them out like this. So she's got that muscle all straightened out, and she's lengthening it there.
Good. She's relaxing.
Good.
Okay, so let's take a look a little lower down the leg here. So again, we were going to see our heel to our seats pretty far here. Okay, so we want to get this a little bit closer. Okay, so again, we're trying to get it just at least this much closer. But what if we got it even closer than that?
Sure. What if we do?
We might do it.
You never know.
Okay, so how comfortable are you up there, Linda? Okay, she's pretty comfortable. Okay, remember, your greater trochanter starts here, comes over here and attaches, so it goes way back here to the hamstrings and way forward into the rectus. So let's go ahead, we're going to go ahead and just give it a little bit of compression here.
You guys remember what the vastus lateralis trigger point or referred pain looks like?
Oh, that's a good one.
It goes way up into the hip. It gives you what you think is greater trochanter bursitis.
Yep.
It goes way down to the underneath the kneecap. It makes you think you have something really wrong with your knee.
Yep, lateral knee.
And it can cause pain right underneath the TFL or the iliotibial tract. So it can cause a lot of pain and dysfunction, but it's a nice way to treat it is while you're stretching it. So that's what we're doing here.
And a good self-care tool for it is that roller.
It is a great tool.
Yeah.
And then also I'm going to just stretch it a little bit. Then I'm going to notice what band fibers stick out when I'm doing that. So I'm going to just take a look here. I can see when I'm stretching it, this one sticks out. Right there. So I'm just using my thumb and pressing in on it. And then I'm also using my fingers, looking for taut bands. I can find some right here.
Extremely tight.
And you can feel that she notices it.
Yeah.
The other one.
Felt different than the other one.
Well, they're both extremely tight in the, is it the rectus femoris that you're doing?
Right. So we're doing a little bit of medius and a little bit of rectus and a little bit of intermedius too. We're getting them all a little bit here. We're getting it. The heel is coming closer to the seat. It's coming a little closer.
Yeah. So we are treating intermedius in the same position.
Yeah. So
intermedius.
But I'm going to do one more special little trick.
Okay. All right.
So that we really get the intermedius more. Because when we're doing the stretch, we're getting the more superficial muscles. And the intermedius is deeper.
Yeah.
So we're going to do a special thing to get that.
What's another muscle, folks, that you can't just treat it on the stretch because you will miss the deeper fibers?
Ooh.
What's another one? Psoas. Yeah, piriformis sometimes too. If you really want to get into deep piriformis, sometimes it's good to shorten it and lengthen it. Completely agree.
Okay, push towards me here. Push a little harder. Push this part, your ankle.
A neat way to treat the piriformis is
like straighten your leg.
When you lie in the stomach.
Push a little harder. Push towards me. Okay, push this way. Push this. Push down. Go like this. Okay, push.
Kick toward the computer there.
Push this way. Just move your leg in that direction, but push. Okay, that's it.
Yeah,
okay, and relax. Good push. Remember that? Yeah, push. Good.
Yeah, I have weakness in this ankle.
Yeah, yeah.
And it's almost like, you know, my brain knows what to do, but it's not going down.
So,
it's not going down to
so
my muscle.
one of the ones that causes really bad ankle pain is this one. The which muscle do you think this is here? That causes really bad ankle pain? Peroneus.
Oh, peroneus.
Peroneus longus is the ankle pain, causes lots of ankle pain and dysfunction. So guess what we're gonna do that? That's coming up in a few weeks.
Ooh, yay!
We're gonna everybody with weak ankles. We're gonna be fixing that. Yeah.
I'll be here.
Okay. So be here. Yes.
I'll be here too.
Okay. So let's have you go ahead and stand up.
Okay.
Okay. So let's see how you feel. Go ahead and stand up and see how everything's feeling. Okay. How does the knees feel?
My knees feel fine.
Good.
This
good.
ankle feels sore.
Oh, you notice the
reason.
ankle. Okay. Yeah. So that we're
not the one that doesn't register in the brain, but the other one.
The other one. Okay. Well, we'll be observing that a little bit too. Okay. So next we're going to do something special. So we're going to treat the vastus intermedius. Maybe we'll look at the ankle one. So the ankle one on the left, right?
Yeah. No, on the right, which
on
is
the
strange.
Right. Got it. Right.
The left one that doesn't is the one that doesn't register.
Okay. So next I'm going to have you sit down on the edge here, and then we're going to have you put your feet right here. You're going to really bend them. Then you're going to lean back, and then we're going to treat right on the vastus intermedius. We're going to do a good job on that. So let's see if you want to go ahead and sit right on the edge.
That's our last muscle. We've done all the ones on the list.
Wow. Okay.
Yeah.
Okay. So then you're going to put your feet up higher, a little higher. Okay. Then when you're ready, you're going to lean back. Yes. Okay.
Wow. This is comfy.
Wasn't it nice? Yeah. So, but it's really good because we're really stretching the glute, the rectus, and the vastus is everything. Yeah.
Mm-hmm.
But now we're going to look at the intermedius here. Okay. So the trigger points for that are up higher too, right here. So we're going to find the superior iliac spine there, and come down a little bit. Let's come right here.
Yeah.
So we're treating it while we're stretching it. Now a lot of times it's less painful when we're stretching it, you know. So this is a half stretch, it's not the full stretch. So it's half stretching. So about here, so now we're getting deep. Can you feel it?
Yes, yes.
We're really in there deep.
But it feels good.
Ha-ha!
It feels good.
She likes it.
Yeah. It's like I can feel the muscle fibers spreading, like they're finally.
That's right. That's what they're doing.
Out.
So that's so when you're so it's while so we're lengthening it, but not a full length, but half lengthening it. We're giving it more opportunity to spread. Yes.
Yeah. The other muscle that you need that for is the psoas.
Well, that's a good way.
You can't get to the deep psoas if you don't shorten it a bit. You won't get to the deep fibers.
So here we are coming along here.
Just a little tender.
But it's easy to treat, isn't it?
Yeah.
It's easy to treat. Yeah. So it's a really good way of treating it. And
much less painful than the other ones.
Yeah. Yeah. So it can be much less painful to treat things on the stretch. Isn't that interesting?
Interesting.
Yeah. So
Really?
so or even in this case a half stretch. So here we're working right through clothes, but often it's good to treat right on the skin as well. So that's always good as well. But it's nice. It's also
I wore my softest,
very nice,
easy pants.
Very nice. Okay, so I feel a little bit more dysfunction right here. So, but I'm going to go through this and go right into the intermedius. So let's start up here. Get right on there. And so I knew I'm using some pretty good pressure for this, but a little more on this side than I am on this one. But what do you think?
Ooh.
Right there, right.
Here's my chihuahua.
Yeah.
My inner chihuahua is coming out.
Aww.
It's chihuahua.
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 Yorkies. Little doggies.
Yochies.
Little doggies. So here, I feel that. Yeah, so a little bit dysfunction right there. So here I found some
like
significant dysfunction here. So I touched it and I just went down, not pressed too hard, just I'm holding it, breathing, relaxing, and seeing if it softens up a bit.
It feels like it's starting to soften.
Nice thing about these classes is that the audience probably have worked on these muscles quite a bit. So it's nice to have some muscles you're more familiar with. And then you can see the extra tips on how to get them really good.
Can you do these in any other way other than your elbow?
Yeah, I like to use my knuckles a lot.
I'm not proficient at elbows.
Oh, yes. So one way that I like to do is have my arms extended, and then I like to go through all the straight through all my bones. And so so I go right through my joints and bones.
So
like
knuckles,
this.
you're using knuckles.
Knuckles, yeah. Knuckles is working really good. Or maybe make it a hair lower, you know, for knuckles.
You mean put the table lower?
I would make the table a hair lower, yeah, for knuckles. So I like. That's good.
Good.
A little more. So
yeah,
knuckles
that feels
is
really
fine.
good.
Knuckles is good, right? And I use knuckles a lot. And I noticed that my bone density tests were really good, you know. So all my bones are
your
dense.
bone density.
And hips, but also the hip ones are super dense. And then everywhere else is dense too. So I feel it's good weight bearing exercise. You know, it's part of it. You know, you're
this
getting
is
some
a plus
weight
for
bearing.
post-menopausal women.
So myofascial trigger point therapy, doing the therapy on other people, can keep you in good shape.
Well, that's why I hope to do it be able to do it as long as I possibly can.
That's it. Okay, so we're all in agreement there. Yes, we like that idea. Okay, so let's take a look at your knee. So it's coming towards your seat nicely. Okay, so I'm just going to look at it just for a minute in range of motion. Could you make the go up a little bit? Yeah. Oh, good. We go up, we go down.
That's
So,
the benefit of
Riverview.
the table.
Yeah. Riverview! Oh, if we could just remember Riverview.
I loved Riverview.
Didn't we love Riverview?
I was very young, of course, when.
She's a few years younger than us, so.
Now that's really sore underneath.
Yeah. So part of bending is also getting the underneath part to bend too. Yeah. So getting all that to bend. Yeah. So just looking at what's letting it bend and what's not.
Yeah, I mean we're treating, you know, for purposes of the class we're treating, you know, protocol 21, pain key area 21, but you know she could have muscles also causing dysfunction that are in other areas. But
okay, great. So we're pretty close to the seat there. That's nice.
Wow.
Yeah. So go ahead and press towards me.
Amazing.
And relax. And towards me.
Yes.
And relax.
Getting
Towards me.
closer.
And relax. Towards me. Good. Super. So we're looking really good. Super great. Let's take a look at this one. So look over here. So it was feeling like well oiled.
Yeah, you got the tin woman here.
Yeah. So the well oiled feeling. Yeah. So I always like to get every little ligament and tendon around the kneecap working. So
Is that what you're doing?
Yeah. And also I'd like to make sure nothing underneath here is stopping you from bending. But I'd like to particularly get right in here and make sure all of these little ligaments and tendons are working.
That's a zinger.
Yeah. So this here, so that should work. Right there.
So are you treating the trigger points in my knee?
Yes, I am.
While you're doing
yes, I am. That is correct.
Range of motion.
That is correct. Yeah. So here I'm getting the.
So you treat on the stretch and you treat on the stretch on the range of motion.
I treat on the stretch, the short, and in full range.
and in between.
Yeah.
Every way she can.
Yeah. So
yeah, there's a lot.
right there.
Whoa, Nelly.
Mm-hmm.
Okay.
So here I'm using fingers. Yeah, right?
Yeah, that's about all I could take. Yeah.
Yeah. So.
Okay.
But I'm not using my elbow here. So you can do it.
Yeah. Well, you couldn't use your. I mean, it would be pretty tricky to use your elbow on this.
Right? We couldn't use our elbow there.
No.
So I fixed somebody's knees from across the street over at they've been going to the
Rehab Institute?
Yes, she knows all. So they after one treatment, they came over here to see what I did to the person. All the PTs came over. because I was doing all this.
I hope the PTs are tuning in.
They came over. They were part of the show. They came part of the show. I showed them stuff.
Oh.
But they were really interested. What did I do? And I was treating all these little ligaments.
Because they're used to doing things like joint mobilization.
Yeah. So they didn't do this stuff. So I got him now. Now he's walking like a champ, and he's got his heels. His seat is doing really well. He's 90.
Wow.
Yeah. Go ahead and push your ankle towards me, and relax. Push towards me, and relax, and push, and relax, and push. Good. Okay, so we're doing good. So on both sides, you've got your 3 fingers. Now, that's good. That's good. So that's.
And what was I before?
5. You're 5 inches, and sometimes you're a little more, depending on which position you're in. Yeah. So that was good. So good. So let's go ahead, and I'll have you help you sit up for a minute. There, and just relax for a moment. And see how you're feeling. Good. Good enough. Okay. Let's have you go ahead and stand up. All right. And then some of our stretches that we'd like to do. So we want to make sure that we get this one in. We want to make sure, so get this one here in. Okay, if you want to do that one. Pelvis, move our pelvis
Hawaiian
around.
Music.
Stretch. Music. That's it.
That's
all
what
the way
I'll
around.
associate it with.
Yep. So we want to do that. And it's also good to walk with our toes in and walk with our toes out. Or just go ahead, we'll just take one. Toe in, toe out, toe in, toe out, and in. Other side. Toe in, toe out, and in, and out, and in. Good. So those are the things that we'll want to do. So we want to get a lot of this in. So go ahead and get this in to your stretching. Mm-hmm.
Oh wow! Yeah.
Oh, yes, you can. Yeah.
I couldn't do it without the wall before.
Well, you were grabbing the tab of your shoe last time.
Yeah, I had to use my shoe, and I had to use this one's a little harder.
I'll help you.
Well, that's the left side, right?
Yeah, that's the injury side. Yeah.
Yeah. So you can use your little strap or a little towel or something, but you want to keep getting that in. Okay, you did really good.
Okay.
You improved.
Thank you.
You improved. She improved. That's great. So it should help you with all kinds of things related to the lateral thigh pain. Yeah, and it won't be so painful when you're using the tools.
Can just do me a favor too. Leaning back, can you lift your knee up as high on that left side? Make sure you brace yourself on the table. Which side is it easier to lift your knee straight up on?
I don't remember.
Good. And then let's look at the other one.
I think this side
This one's
is
easier.
It's easier, right?
This one's easier.
What does the left feel? Heavy, weak?
Weak.
Weak. Try lifting your leg out to the side.
Okay. Oh, he's doing a little.
And that side. And how about the other side? Which side feels stronger?
Oops.
Right side feels stronger?
Yes.
Yep. And how about heel to the buttocks? Just without using your hand, just using your muscles only, just your hamstrings?
Yeah, I can't get very far.
You can't get very far. Well,
we might have an impacted hip then.
We have a compacted hip, most likely. The diagnosis of compaction
But I don't have bursitis anymore, right?
Yeah. The diagnosis,
I tried a diagnosis.
The diagnosis of a compaction is all the muscles in the joint, and they only happen in ball and socket joints, the hip and the shoulder being the only 2 ones we really care about. All the ball and the socket get jammed together, and one muscle becomes very tight and shuts off all the others, so the whole leg feels weak and heavy. All the muscles are operating at like 30 to 50% of their normal strength. It's like a dimmer switch has come on all the hip muscles. And that's a hip compaction. And when that happens, one muscle will get real tight, the rest will be weak, and you'll start having to swing your hip around with your low back, and everything will just start getting real tight on that side. And that happens frequently after an injury. And you said that was your injury side. So you said after an injury, what happens sometimes in the muscles is these little Golgi tendon organs. Let me show you.
So I injured both my ankle, my knee, and had the chronic SI joint stuff going on.
Wow.
You see, right here at the origin insertion of the muscle, right where the Golgi, right where the tendon and muscle join, that's the Golgi tendon organ. If that muscle fiber gets injured a little, overstretched or something, it will send a signal to the dorsal horn of the brain, to the dorsal horn of the spinal cord to tell it to shut that muscle off. This is the dorsal horn. This is the motor neuron that goes to the muscle. This is the neuromuscular junction, right? This is where you find the trigger points, but this is where you find origin insertion injuries. So when this Golgi tendon organ sends a little signal to the brain, it sends a negative signal to the motor neuron and shuts off that muscle. Now, not completely, because some of the neurons will get out to the muscle, so some parts of the muscle will fire, but lots of parts of the muscle will not fire, and that's what causes that feeling of weakness. Do you mind walking for us, and can we just walk down the hall?
Is that initially a protective device?
It's a protective device.
Trying to save?
Yeah.
Okay. Where do you want me to walk?
Just walk down the hall, and just walk slowly, and I just want to see, if you'll notice, I'm more just dropping, and just kind of on the left side, can you see how that hip just kind of like, just smacks more? There's a heavier, harder hit on the left.
Yeah. You can even see how I wear my shoes, that there's like a big...
you see how that left hip hits?
And sometimes I kind of like stumble with this foot, almost like I have like...
So drop foot on the right.
Yeah, that's probably a different thing.
Yeah.
But yeah. Okay, walk a little faster on the way back, and then you'll really see, you'll start to see how that left... See how it kind of, her body comes down? I'll exaggerate it, but it's like comes down.
Yeah, like I'm
pounding on that left hip. Like it just comes down on that left hip. And you'll see it, what happens when they're 70 or 80 years old. Then you see them walking with canes on that side, and they're just pounding on that one side,
that's why I thought that I had one shorter than the other. So look at this. How my shoe is worn. It's almost worn through.
On the one side where you're pounding a lot
heavier. This is the left, yeah.
Right.
Yeah, exactly. Okay, so here's the thing. Sharon would have ended up fixing this anyway. If you do good trigger point therapy, you're going to fix it anyway. But if you wanted, since we promised we'd show a little bit of trigger point kinesiology, let me just show you what you guys are doing. You don't necessarily have to learn how to do this, but let me just show you how awesome your work is. If you lie on your back for me. Oh, sorry. Too sorry.
You raised the table.
Sorry. I raised it for
She raised
myself.
it for the therapist. But we have stools.
Yeah.
You have my feet down.
That's just like this. Perfect. Okay, you can just lie back. All right, so the tensor fasciae lata, for example, is here, and it kind of rotates around. So to take and make the muscle fibers straight like this, because it goes like this, kind of curves around. So to take it, make it straight. To muscle test, what you do is you keep the muscle in a straight position and you push exactly 90 degrees opposite to the normal muscle. So I'm going to have you push first into my hand, up and out that way, and I'm going to push against your hand. And I'll add resistance. You try and meet my resistance. As I add more, add. You see it's very weak?
Very weak, yeah.
Yeah. And we'll do the same thing on this side. Push up and out again. And you see how much stronger it is on that side?
Much stronger.
Okay. Feel that again. Push up and out. See, it's almost like there's no go, nothing you can do, right? Yeah. Okay. Tensor. How about the rectus femoris? To test the rectus femoris, we put the muscle in a straight position, and I push linearly against this. So you push into my hand first. The patient always pushes first. Push first, and I add more. Yeah. They should be able to meet. You should be able to add 3 or 4 or 5 levels of additional strength, and they should be able to match that. So you push first, let them push first, and I push. Then I add 1, 2, 3, 4, 5. You see, 5 additional increments of strength that couldn't do on this side, right? How about hamstrings? Hamstrings pull the heel to the buttocks. She couldn't pull her heel up on this side to grab it. So you pull into my hand first.
Pull?
Yeah, heel toward the buttocks.
Oh,
pull.
okay.
And then I'm just going to add 1, 2. See, I can't even add 2. And it says
Can't
pull.
add 2.
Pull again. Pull as hard as you can. $100 if you can keep this here.
I lost again.
Dr. George Goodhart, the inventor of applied kinesiology, used to put $100 bills on the chest, and he'd say, "Come on, just hold it. You get to keep this if you hold it." Okay, same thing on that side. Pull, heel. Okay, and then I'm going to add 1, 2, 3, 4, 5. Okay, good. So those are all strong. So what does that mean? That means that at some point, we're looking very likely like this hip got compacted. Now you want to see a miracle? Watch
Sure.
this. I'm just going
It's the
to
next best thing to 100 bucks.
distract the hip, which is the opposite of compaction.
Mm-hmm.
So the hip joint is like this right now, and I'm pulling it apart. It resets momentarily those neurological circuits.
Right.
And now look, I'm not going to offer you $100 on this. Push up and out. Holy cow, bingo. 1, 2, 3, 4, 5. Or, how about this? Heel toward the buttocks. Ooh, look at that. 1, 2, 3, 4, 5. Yeah. Or, right here, push. Knee that way. 1, 2, 3. Okay, good. So, that's really good. So you're all fixed, right?
You're my hero.
Until this happens.
Ow.
The
Right?
compacting again.
Push up and out. Oh, what happened? Or full at the heel. Oh no, right? So that isn't nearly as much as your own body weight. So the second you go to stand on it, it's going to do that. So what's the secret? The secret is there is one muscle, we haven't found it yet, that is tight and it is not letting go. Those are the dysfunctioning GTOs. Those are the Golgi tendon organs that are sending the signals to shut the entire hip off. Let's test a few more. How about piriformis? To test the piriformis in this position, it becomes an internal rotator at this position. So keep your ankle here, and I'm going to twist out. You
Am I
twist this
supposed to
way.
resist?
Yeah. No, that's not the one. How about heel down into the table, and I'm going to pull up? No, that's not the one. We'll find it. Glute minimus, push down. I'm sorry, glute medius, push down and out. Oh, that's it. That's the one. So glute medius, which is the only one we didn't treat today because it's not part of the protocol.
That's right.
See how I said Sharon would have fixed this anyway?
Because it's weak.
It's strong.
It's-
Push
oh,
down
it's-
and out. Push
So
down and
all
out.
the others were weak, and that one was strong.
That's the only one that's strong.
Oh, okay.
Okay?
So that's the one that's switching the other ones off?
Yes. Yep. So you
The
go to
gluteus.
Medius.
the gluteus medius.
And also the shoe inserts are correcting that one too.
Yeah, exactly. So the origin insertion of the gluteus medius,
Yes.
it inserts onto the lesser or the greater trochanter
That's right.
here.
Right there.
Okay.
So I know it's a little tender, but those are where the Golgi tendon organs are going to be screaming bloody murder, and they're shutting off the rest of the entire hip. And Sharon would have fixed it, except it wasn't on the list today. And all of you would have fixed it, but it wasn't on the list today. Okay. Okay. And the other end of it is right up here, where it inserts onto the iliac crest, right? Right here. And that's all along the upper ridge. Breathe. You get through it. Now this is down and dirty. I'm not doing it as well as Sharon would because I went for demonstration purposes. She'll go home and do a much better job of this with self-care and all sorts of stuff. And Sharon would do the side lying position with the elbow and the forearm, of course. And after I work on those points, I just go ahead and distract the hip again for just a second. Okay? Now, that did how much change to the tissue? Just a little bit, if any, right? What it did was it changed the neurology. So the nervous system, if you push up and out now, strong, right? Bring up here, this way with the knee, strong, okay. Heel toward the buttocks, okay, strong. Piriformis, ankle toward that window, strong. Glute max, heel toward the floor, table, yeah. Strong, okay. And just to make sure we didn't, not as painful?
No.
Exactly. Heel toward the buttocks again.
Still strong.
Still strong, right? Up and out, TFL, strong. Heel toward the floor for the glute max. Super strong. Good, and that's good enough. So get up and see the difference in some of the things you had trouble doing. You had trouble lifting that knee up on its own. Wow. Like a miracle. Like all of a sudden that knee can be easily lifted, right?
Yes.
And my balance, I mean, before I'd feel like I'm going to topple over. It's so weak that I'm going to topple over.
How about you couldn't grab your heel when you did the hamstrings, or when you did the quad stretch?
Like this one? Mm-hmm.
You might want to balance.
Still not quite, but.
Mm-hmm.
Maybe more of a flexibility issue, but you're able to pull it up, right? Good. And then walk for us again. Sorry.
Look, I'm glad.
Smoother, more even. A little bit of a wag there. No more dropping. No more of that old lady thump on the left, right? How does it feel?
Much better.
Right?
Wow.
My hero.
No.
Well, you said you'd make us look like heroes to our clients, so.
Yeah, I'm just showing you what you guys are doing. Yeah. You might as well know that you're not only affecting tissue, you're affecting neurology when you're doing that work. Mm-hmm. Okay? So, not just the belly.
But the kinesiology made the difference.
The kinesiology was just a way of demonstrating what Sharon would have done, or anyone would have done. If glute medius was on the list today, she would have treated that origin insertion point anyway. You see? So the trick is you treat you treat the full length of the muscle, and make sure you get the origin, make sure you get the insertion, because there are the switches that control the tone of that muscle. And hip compaction
Not
is
just
so
the belly of the
common.
Muscle.
Right. The belly's good for the referred pain.
Yeah. Now there's only one thing you have to do to keep your hip from getting compacted again, because it won't come back. Neurological fixes stay fixed unless one thing happens. If you get dehydrated, that hip joint capsule will start to shrink because it's all fluid in there, and that will cause a compaction to come back. So to demonstrate the extreme importance of this, I had a doctorate of psychology in my office, a PhD of psychology. She had a terrible hip problem, and it was a compaction. I fixed it in 2 minutes like I did yours in between patients. And she was like, this is a miracle. And I demonstrated for her how when she drank water, all the hip muscles immediately reacted like, oh yeah, that's what we need. She went home that night, called me and said, it didn't last. Your treatment didn't work. And I said, have you had any water since the treatment? Oh, they drank a cup of water, and within an hour it was better. The next morning, she came to work. She said, it's still sore this morning. I said, have you had any water this morning? She said, no. She drank a glass of water, and immediately it got better. So she said, you were serious. I said, absolutely serious. The joint needs water. If your body is dehydrated and it's using water to detoxify, it's using water to keep your blood level counts, blood volume up. If it needs water, it's going to take it from the joint where it's not life-threatening. So the first place it's going to rob water from is that hip joint. So you need to keep that hydrated, okay? And then you need to keep the self-care to make sure you get the origin insertion of that glute medius, okay?
Should I work on that myself?
Yeah, definitely. That's going to be the key to all the strength coming back and staying back in your hip.
So how do we treat the glute medius? We find the greater trochanter and go up and press up towards the iliac crest. So we're going to treat that there. So let's go ahead and let's treat that.
Should we do it? Yeah,
let's go ahead and treat it.
Why don't we have Sharon show us the right way, since I did the down and dirty way. I never did the muscle treatment in my office. I had Sharon and her team do all the muscle treatment. I just diagnosed which ones. Right? Do you want to do self-care, or do you want to do treatment?
Self-care. You said you set it up for treatment. Let's do treatment. Okay, let's go ahead. Have you go ahead and come up here and lay down.
Me again?
Yeah, left glute medius. She's going to get it real good. Not like I did.
I thought that was real good. I thought that was very good.
Okay, so go ahead and lay on your back. Yeah. So one good way to treat the glute medius is to put it on the stretch. you know, so you can get it. So this would be a way that I could treat you. So here we're going to be treating it while we're stretching it. So since you're standing there, I'll do it this way. So we'll do it this side. So let's treat the gluteus medius right here. So we'll go ahead and treat that while we're stretching it. And go ahead and press your leg towards the door. Push and relax. Good. And push. Good. So let's take a look at. I'll do it with my elbow on that side.
Do you have to?
So here. So, we can do fingers.
Or knuckles.
Knuckles. We can
Mother
do
muscles.
knuckles.
We like those knuckles.
Yeah, we do that. We'll do the fingers, knuckles. So here we go this way. So
Oh, yes.
Yeah. So here is a good way to get the attachments of the glute medius here. So
Yeah.
we're right on the
Beautiful. Yes.
the attachments on it right there.
See, that feels a lot better than the way I
Yes.
Yeah,
Yes.
push
See?
Push towards me a little bit. Push.
Oh,
And
which
relax.
way?
Push towards me a little bit.
Oh,
And relax.
okay.
Good. And push. So we can feel some taut bands right here.
Yeah.
So this is a good way of treating up
Yeah,
like
right
this.
there, yeah.
Mm-hmm. Without your
Now
elbow.
that must be what I thought was
Mm-hmm. This
sciatica.
Well, yes, because the gluteus medius and the gluteus, especially the minimus, it causes pseudo sciatica. The two of them together will cause hip pain and sciatica. Yeah.
So that's it. You guys are fixing hip compaction.
So then
all
another
day long.
another diagnosis that I'm abandoning.
Yeah, let's abandon all these diagnoses.
Well, if the diagnosis doesn't tell you how to fix it, it's not a very useful diagnosis, is it?
We have to give it a new name. The
Yeah.
diagnosis.
See, hip compaction says you can uncompact
Now it
the
seems
hip.
like
you
you're
know.
doing the sacrum.
Well, I'm getting the gluteus maximus right there. Attachments
Like
on
the
sacrum.
attachment. The attachment.
Yeah,
of the
on the sacrum.
Okay.
Yeah.
Yeah.
So here with the gluteus medius. Good. Okay, so push towards me. Nice. And relax. And push. Okay, let's look at the nerve roots. Okay, let's look right here and see what
Oh, yeah.
what their contribution is to it.
Absolutely.
Oh, look at the nerve root.
You see how easy my life was as a chiropractor?
No, I'm not feeling any. I'm
Yeah, but
I'm
look at-
curious.
Let's see your legs coming closer to your chest.
Oh, is that what's happening
yeah.
in this lifetime?
Yeah,
yet?
yeah.
In this lifetime. Oh my gosh, it really is too.
Oh, now that's a
Look
good
at
one.
that.
That one's
So
tender.
this is S1. Okay, right here. So here we're at S1. Okay, so you can see that those are so these nerve compressions, slight nerve compression here at S1, L5 are causing a little trouble.
When I was
Push towards me.
when I was in high school, I
Yeah,
worked
nice.
at a pancake house, and I had to do everything: bus tables, take orders,
Oh
clear,
yeah, that's sore.
everything. When I got older, I did fine dining, and I didn't even
So
have to bring
you're
the
not
food out.
compressing the nerves. The nerves are compressed.
Yeah.
But you're treating
We're treating
the trigger points
well, remember,
in the muscles that
we're
are
treating the
compressing
muscles. Yeah.
the
so,
nerves.
so but the gluteus medius was causing all the other imbalances with the other muscles.
Yeah.
Remember? Yeah.
The
Okay,
gluteus
so-
medius was neurologically inhibiting all the other muscles in that hip.
Yeah. So
That is a phenomenon unique to ball and socket joints called a compaction.
yeah. So here we go a little bit better. So now we're
So do you
7.5
think
inches.
do you think
yeah.
people end up having hip replacements because of that?
Oh,
Completely.
Oh,
If you
yes.
keep walking on that and only one muscle is
Yes.
firing and the rest of them are
They're going
inhibited
boom, boom,
every
boom,
single time,
day.
yep.
Full weight.
for years and years, of course,
yeah.
that's the reason.
Sure.
Now, is it usually gluteus medius, or can it be a different muscle?
The most common muscle is piriformis. The second most common is gluteus medius. The third most common is
Okay, let's
rectus
turn to one
femoris,
side.
and the
Let's
fourth
see if you
most
stand
common
up.
is hamstring.
Okay, so it could be any
she was
one
the
of
second
those.
most common. Yeah,
All right,
any
let's
one of
have
those
you stand
muscles.
up. Okay, so next week, what are we doing?
Oh gosh, we've got more thigh to do. There's yet more
yeah,
thigh.
we've got more things to do.
Okay.
Yeah. Yeah.
So next week we're going to do protocol. So this one we did 21. So
Right.
next we're going to do 22.
22.
So right here. So here's the muscles for 22, and then what I need you to do is to download it off of our website here. So, but the most common muscle to cause this anterior thigh pain
Adductors. Oh yeah.
is the adductor longus and brevis, the iliopsoas, the adductor magnus, vastus intermedius, then the pectineus, the sartorius, quadratus lumborum, and rectus femoris.
If you guys want, I'll teach you how to test those muscles. Same thing. Those have some unique tests next week, too.
Strength tests. So,
that would be
Yeah.
exciting.
So muscle tests
so
are...
we're looking. We have two kinds of tests: the range of motion test
Yep.
for the length of the muscle, and then also we'd have the strength test.
Yeah, strength and length. Both of
Strength
them are
and
good
length.
tests.
Yeah. Okay, so this is for next time. So download it and be ready.
Okay, great. Thank you, everybody.
All right, we're ready. So we'll do a little bit of our range of motion exercise.
Yeah, let's do some range of motion. Let's review the range of motion one last time.
I think I've never had this much relaxation. And
You feel the
my-
release, your whole,
Yeah.
everything that was doing the work of those hip muscles is now getting to relax. Amazing, right?
Because I've been walking around feeling like,
Oh, well, the QL is swinging your hip around. You know? It's just crazy.
Sharon and Justin from Pain Free,
Right.
who want you to remain free.
Forward.
We will assess and use heat,
And back.
then compress and repeat. When our trigger point is there,
Back. Now the other way.
we'll teach you how to do self-care. This will keep you at your peak.
And out.
So see you back
Other foot.
again next week.
See you guys. Thanks for viewing and practicing and helping people.